I now invite Dr. Bala Venkat to start the session.
Madam, can I share my screen?
Yes, sir.
I think I need the permission for that. Madam, you can close your, Dr. Neelam, madam, can you close your...
Dr. Neelam, can you stop sharing?
No, yeah, it's fine.
Yeah. Dr. Bala Venkat sir is such a visionary leader and so inspiring. He always is trying to make anesthesia a best and a well acknowledged profession, not only in India, but world over. So we are so proud of you.
Thank you so much, madam. Thank you for that warm and nice introduction, Dr. Neelam. The president of the Borivali Society, Amala madam, Vice President, Dr. Rajiv, Secretary, Dr. Rajesh Rao, the Scientific Chair, Tajveer Singh Chauhan, and I also saw the SAMS Academic Vice President, Dr. Saurav Bharde, all the senior professionals from the reputed ISA Borivali branch and senior members of the profession. I'm extremely happy to share the stage with, I would say, my mentor and immediate past president, Dr. J.V. Dipatia sir, who is a co-speaker for this session, and the GC member, Indrani Hemant Kumar madam. Such a pleasure that all of us work towards a common goal of making anesthesia safe to our patients, and we give our best to our patients. This meeting is very important for me because I think this is the first ever official ISA meeting that I'm addressing as after assuming the office of the President of Indian Society of Anesthesiology. I thank all the moderators. I see 3 from the President, Vice President, and Secretary of the Borivali branch, and Dr. Shilpa Tivaskar moderating this session. I bring to you greetings from Ganga Medical Center and Hospital and the city of Coimbatore. I made it a point to open my presentations with this slide because yoga seems to modify several things in our life, including possibly the response to malignancy. Yoga seems to be a perfect blend where internal physiology becomes better and immunity is better. And probably, I think research will take us towards seeing the neurochemicals and what happens in the microenvironment of tumor cells due to yoga. I think that day is not far away. And I think all of us are striving hard in ISA to advance the quality of patient care. And I thank ISA Borivali and SAM's leadership for doing this in abundance. And that was obvious in the recently concluded conference, the national conference at Patna, when the SAMs and the multiple branches of ISA branches, city branches in Maharashtra bagged several awards. And I can still remember, I think it needs to do yoga to carry all the certificates. You need that physical capability because you bag so many certificates. And I said, this is my first academic session in my new responsibility. But since it's the first time, I just wanted to share with you that several initiatives that have been proposed and been activated by immediate past President Dr. Dipatia will continue this year. And one of the most important things will be the College of ISA, which will result in ISA turning into a pure academic body with definitive Indian guidelines and advocacy, fellowships, simulation-based learning, the ISA module to decrease the perioperative morbidity and mortality, also move towards global networking and showcase the excellent work done by Indian anesthesiologists to the world, and an ISA app, data mining, audits, and the outcomes of that and also focus on member well-being. I wanted to share with all of you an conference par excellence, an immaculate conference, ISACON 2024, conducted at Patna. Absolutely superb it was in all aspects. And we feel very happy that ISA conferences are becoming better and better. And I'm sure that we will try to match the best global conference. And that would be our focus in the next upcoming conference, ISACON 2025 at Raipur. I also, being the secretary of the World Federation of Society of Anesthesiologists, just wanted to share a couple of slides. I've been asked to by the board to speak about 2 to 3 minutes about the World Federation. In every meeting, I speak as a president. And so, true to my WFSA president, Dr. Daniela Filipiscu from Romania, as a secretary of the WFSA, I just wanted to say World Federation of Society of Anesthesiologists is the prime organization in the world which has got 141 member societies from 150 countries. It represents the anesthesiologists around the world with a clear vision of universal access to safe anesthesia. And the mission is to unite and empower anesthesiologists around the world to improve patient care. And our 5 strategic priorities now, starting from 2023 to 2028, will be champion the vital role of anesthesiologists in the global and planetary health, strengthen member societies and enhance professional networks, advance anesthesiologist leadership within healthcare, which ISA would do it uh, quite abundantly in the years to come, work with member societies to ensure a well-trained and resilient workforce, improve safety and quality in anesthesiology. And the strategic keywords are educate, collaborate, and advocate. I take this opportunity to welcome you all and mark your dates for the next World Congress of Anesthesia, which is to be held in Marrakesh, Morocco from 15th to 19th April 2026. I have told them that we will have a large Indian delegation with enough number of presentations that the world will get that message that Indian anesthesiologists do extremely good work. And I've set the target of minimum 500 anesthesiologists with 500 presentations in the next World Congress. And I'm sure, Amala Parikh, madam, you will bring a big delegation from Borivali branch, at least 25 presentations from Borivali branch, and show them what the private practitioners and the corporate sectors in India do, apart from the work done in institutions and medical colleges. I bring you greetings from Ganga Medical Center and Hospital, Coimbatore, predominantly an orthopedic and trauma hospital. But the last 3 years, we moved into onco work. We do a lot of orthopedic onco work, and upper airway, we have a full-fledged the onco surgeon and medical oncologist, radiation oncologist, and reconstructive surgeons who do a lot of onco work. So slowly we have branched into onco work. And also I take this opportunity in my own behalf as the conference chair of the Ganga Anesthesia Refresher Course 2025. GARCindia.com is the website, and I request all those who have time to join us in this endeavor to make anesthesia more safe. Regional anesthesia and analgesia seems to have revolutionized several facets of perioperative care, and similarly in oncosurgeries. And when you talk about oncosurgery, pain is a significant component the patient has, immaterial of where the malignancy is. Because of the nature of the disease itself, pain seems to be an inherent component. So before we operate, after we operate, and those whom we cannot operate, it's important that we serve as their angels in decreasing their pain. And it is very important that we need to master everything that is needed to achieve this. So this slide, I always want to get inspired, because excellence is never an accident. And we need to keep on doing things in our clinical practice so that it becomes very simple to us. So masters make everything look so simple. The most brilliant of the best do their craft with effortless ease and exceptional grace, or at least make it look the way to you and me. So for this, we need to say yes to the technology. And the one which we need to say yes as far as regional is concerned is ultrasound. So when you talk about onco, the main and the most important component, as I said, is pain relief. It should be both pharmacological and non-pharmacological. And that's why we call it as multimodal. But in this treatment, like analgesic treatment, the one which seems to be of great help, apart from the non-opioid and opioid analgesics, is regional anesthesia and certain adjuvants like corticosteroids and anticonvulsants. So we use a combination of all these things. But today I'm going to focus on the regional component. The regional seems to have made an inroad into onco procedures. Number one, in pain relief and acute pain relief, and also once acute pain is alleviated in onco patients, the development of chronic pain syndromes become less. If if there is a tumor cell and it keeps proliferating and it keeps stimulating the nociceptor, and if the pain is conveyed to the spinal cord, and if it goes unabated, it has been found that excitatory neuropathways develop, and this becomes a problem. And this aberrant excitatory neural pathways that develop result in significant pain and resulting in pain syndromes, the chronic pain syndrome. So it becomes very crucial that the minute you see the patient, we take measures to block that particular nerve which is taking the pain from the site of malignancy to the spinal cord. So acute pain relief is crucial, very important. And more interestingly, of late we have found out that regional anesthesia reduces the surgical stress response in the perioperative period of every surgery, and in particular oncosurgeries, which may help to preserve the immune system's ability to eliminate cancer cells. Lot of research is going on into this aspect of oncology, and multiple studies focusing on biochemical markers to see if you administered a regional anesthesia and analgesia, whether the biochemical markers, which results in enhancing and proliferating the tumor cells, becomes less. And there seems to be some good news, and though it's not been clearly established, but majority of the studies go on to prove that the pro-inflammatory substances are less. And we are not only sure about the anti-inflammatory cells, but pro-inflammatory substances are definitely less. And this is supposed to enhance certain internal biochemical substances like CD56, which is very, very good in case of tumor. And also, when you give regional analgesia and anesthesia as a component of general anesthesia, even if you give a GA to the onco patient, if you give additionally a regional anesthetic technique, for example, if it is a CA breast, we do it under general anesthesia. But if you give an additional regional anesthetic block, for example, thoracic paravertebral block or any of the interfacial plane blocks, the advantages seem to be, because you gave a regional, the requirement of the general anesthetic agent becomes less. The amount of opioids that you use becomes less. And these two things seem to help in better outcome in onco patients, because the general anesthesia drugs seem to help the tumor activity. And that of the RA, by reducing this, will decrease the effects of tumor progress. These are very interestingly poised. And also, there are few studies to show that local anesthetic solution by itself work as drugs which will work against the tumor cells and will enhance the apoptosis of the tumor cells. So all this seem to tell us that even though it may not be really confirmed, but it's moving towards this direction. So I strongly recommend that all of us embark on a journey of incorporating a regional technique to all our patients who are going onco-surgery with potentially good benefit coming to them, not only for pain relief, but also more than that. So improved outcomes is what we expect. So this is just a flow diagram to show that the pro-inflammatory substances or block as a component of the surgical stage following tissue damage in surgery, and also the pain, by alleviating pain, the immune suppression that happens, the decrease in NK cells. This has been one big study on NK cell concentration, the decrease in that, and regional anesthesia. In these group of, in that particular study, it shows that patients who underwent thoracic paravertebral block for breast surgeries had decreased immune suppression versus the ones who did not have and who did was done only under general anesthesia. And maintaining the level of NK cells seems to be very, very helpful in decreasing the progression of the tumor cells and the metastatic spread. So in all, it goes to prove that this seems to be very, very useful. So this just to RA is proposed to reduce the incidence of cancer recurrence by attenuating the sympathetic nervous system response to surgical insult, by reducing the perioperative requirement of opioid, and lastly, by the direct effect of local anesthetic, possibly by systemic absorption. Amide local anesthetic used in regional anesthesia, lidocaine, bupivacaine, ropivacaine, have anti-cancer properties, and they enhance NK cell activity by activating apoptotic pathways. So this has been shown in breast, gastric, and prostate malignancy. This is a summing up of the certain inferences that we have obtained. This is an excellent article, Impact of Regional Anesthesia on Recurrence, Metastasis, and Immune Response in Breast Cancer Surgeries. And I would recommend all of you are listening to this talk to read about this, because it gives a lot of insight into what happens when you give a thoracic paravertebral block along with general anesthesia minus a thoracic paravertebral block. Just case is done only under general anesthesia. So I think the conclusion is PVB is associated with lower levels of inflammation and better immune response in comparison with general anesthesia and opioid-based analgesia. Long-term outcomes, we are not sure, but it seems to be quite good. Are cure rates for breast cancer improved by local and regional anesthesia? This is yet another interesting study that's been conducted. And again, it's an original article. And again, it goes to say that RA seems to be superior. And this is what is concluded. When it is used, when thoracic paravertebral block is used as an adjunct to general anesthesia, it was associated with a remarkable four-fold reduction in breast cancer recurrence compared with GA alone. So the follow-up studies from these investigations demonstrated that the patient pro-inflammatory cytokine profiles were more favorable for cancer immune competence in patients receiving regional anesthesia, presumably because of the attenuation of the neuroendocrine stress response to surgery. Many studies of the cell-mediated immunity, cell signaling pathways affecting immunity, and other molecular mediators have now published, citing the potential advantages of regional anesthesia over GA. So this is something which we really need to take into account. Apart from this, another important thing in patients who undergo breast surgeries has been persistent pain after breast surgery. And it becomes important that we prevent this, because it definitely brings down the quality of their activity of daily living. So initially, it was only thoracic paravertebral block, but now plenty of interfacial plane blocks have come into vogue. And quickly, I will go through some of them, which are very, very crucial and important. They provide excellent perioperative analgesia. They reduce pain score in the first 24 hours and also decrease the opioid consumption in the first 12 hours. Less of nausea, vomiting, less sedation, and early weaning, early extubation, and shorter PACU stay and hospital stay. So in breast surgeries, apart from thoracic paravertebral, interfacial plane block seems to be doing an um, excellent outcomes. So traditionally it has been the thoracic paravertebral block, and I think the perioperative breast analgesia, in several reviews that I've done, still thoracic paravertebral block continues to be the gold standard, and it also has shown that in multiple studies, it's shown that the recurrence rates are less and survival seems to be better. Now, one important aspect that every anesthesiologist should know and should discuss with the surgeon is which block to choose. If it's thoracic paravertebral, it covers everything, most of the things. But if you go for interfacial plane, what interfacial plane block that you would like to administer, for example, in breast surgery, depends upon what exactly the surgeon wants to do. So the dermatome, the myotome, and the osteotome that would be involved in that particular technique should all be covered by the interfacial plane block that you choose. And it's also very important to discuss with them whether it's going to have an extension into the axillary region, because post-mastectomy pain syndromes are extremely common, and a very, very high percentage of patients have this. And there are several studies across the globe which shows that the focus has been on intercostal nerves, but the main pain happened because of the injury to the intercostobrachial nerve and the neuromas that are developing because of that. So this needs to be kept in mind, and an important component to prevent post-mastectomy pain. So a quick note about the chest wall. This is very important to know. I just took breast surgery as a prototype because a lot of advancement has happened after the advent of ultrasound using multiple interfacial plane blocks for breast surgeries. So all that we need to know is uh, it is all supplied by three different. The supraclavicular nerve is a component of the cervical plexus. So it supplies the dermatome, which you see just below the clavicle. Then the other two important nerves are the lateral pectoral and the medial pectoral nerve. And then you see laterally the intercostobrachial, long thoracic nerve, and thoracodorsal nerve. And lower down, you come to the intercostal nerve, the lateral cutaneous branches, and the anterior cutaneous branches. So it is important for an anesthesiologist to know that these are all the nerves that need to be blocked in breast surgery. Of this, you definitely know that when you use a thoracic paravertebral block, you will definitely not be able to block the supraclavicular nerve. So that has to be kept in mind. And when we use a thoracic paravertebral, you need to supplement those those nerves which are not blocked by thoracic paravertebral. And an anatomy of the intercostal nerve is very important for all of us to know that it's got a lateral twig and an anterior twig. And these are the things that we block and never interfacial plane block. A quick review. So the cutaneous and subcutaneous innervation is for the breast supraclavicular nerve. Like we said, it's from the cervical plexus. The lateral cutaneous branches of the intercostal nerve, both the anterior and the posterior division from T1 to T7, supplies the breast region, and the medial cutaneous branches T1 to T6 and the intercostobrachial. So this innervation, all of us should know. And the innervation of the muscles of the chest wall, they are predominantly they're coming from the brachial plexus. So the lateral pectoral nerve, the medial pectoral nerve, long thoracic nerve, and the thoracodorsal nerve. So these two slides are so crucial and important for us to choose what you would exactly would want to do. And the post-surgical neuropathic pain has always been secondary to direct nerve injury or radiation or prolonged traction during the surgical procedure. Now, I will quickly go on to the transducers that you would use, either a high-frequency transducer for superficial interfacial plane block or a curvilinear probe for thoracic paravertebral block. So this all of you would be well versed with, but for just updating it for the young minds who have not done it. I think this is one of the best blocks to do, where you call it as the gold standard block for breast surgeries. So this is how we do it. So you see, I mean, because he's a thin individual, we are using a linear probe, and the probe is kept just lateral to the spinous processes. And what you would wanted to see is you wanted to see the space between two transverse process, and from you will see the trapezius, rhomboides, and erector spinae muscle. You see the two transverse process, and between the two transverse process, you will see the superior costotransverse ligament. This is very important hyperechoic structure that you will see within the transverse process, and your needle should pierce this, and you need to stop immediately after piercing. And when you inject the drug, the pleura which is seen below dips down. So that's the classic way of giving a thoracic paravertebral block. And this is the sonoanatomy. You see the both the transverse process, and you see the intercostal. In the green you see the hyperechoic superior costotransverse ligament noted, and the glistening structure lower down is the pleura. So we place the drug after piercing the superior costotransverse ligament. So that's the space where you inject the drug, and that's how you give a thoracic paravertebral block. You can either do with a paramedian approach, or you will do it with a transverse approach. And when we do it with the transverse approach, you will see the superior costotransverse ligament and the pleura, and you see the pitch between the two. That's the space where we inject the drug. So this needs a little more experience and expertise to do a paravertebral block, but I hear that several of the young anesthesiologists have embarked on doing thoracic paravertebral block after the advent of ultrasound. So the drug that you need to use on one side will be about 0.25% bupivacaine, about 20 to 30 ml. And if you put a catheter, you need to give about 8 to 10 ml per hour. The next block, which has become extremely popular now, simple to use, for those who find it difficult to use a thoracic paravertebral, can go for an erector spinae block. It is a C1-do-1 block, and something which can be done. It's almost similar the sonoanatomy that what you saw for thoracic paravertebral, but here indeed we don't go deep inside. We go and hit the transverse process and place the drug between erector spinae and transverse process. So you see the glistening, and that's how you place. You hit the transverse process and you place the drug about 15 to 20 ml on either side to give a good spread, and it produces an excellent analgesia. Though the visceral component is not taken care of, the somatic component is taken care of extremely well. So that's about the erector spinae block. The complications are much less than that of thoracic paravertebral block. The other blocks that you have to know just for quick completion is PEC1 block. And the PEC1 block is you place the probe anteriorly, you place the linear probe just below the clavicle, look for the pectoralis major and minor, and you place the drug between the major and minor. That's PEC1 block. And the next thing that you would, so that's the PEC1 block that you will place, and you will place about 10 to 15 ml of your local anesthetic solution of 0.25% bupivacaine. It blocks the lateral pectoral and the medial pectoral now. So the next one which we go is the PEC2 block, and so it is 2 injections. The first injection is between pectoralis major and pectoralis minor, and the second injection is between pectoralis minor and the serratus anterior. So the PEC2 block is the second block, intercostal plane block, that you would need to master when you go into embark on the journey of doing the breast procedure. And the advantage of PEC2 over PEC1 is it also blocks, apart from the lateral and the medial pectoral nerve, it also blocks the anterior division of T2 to T6, and also the long thoracic nerve and the thoracodorsal nerve. So the serratus plain block is the new nomenclatures have arrived to show you a serratus plain block. So you saw PIC 1, you saw PIC 2, and this is the serratus anterior plain block, which is divided into superficial and deep. And at the level of the fifth rib, you will place the drug between the latissimus dorsi and the serratus anterior. And that's a superficial one, and in the deep one, you place between the rib and the serratus anterior. So this advantage of this is it also covers the anterior division much wider than the PEG2, T2 to T9, and also takes into account long thoracic nerve and thoracodorsal nerve. So anterior cutaneous branches, if we need to block, is the pectointercostal plain block. It's very simple to do. You place the drug between pectoralis major and the intercostal. So this is when the surgery goes much more anterior in breast surgery, and we inject about 10 to 15 ml of the drug. And the next block described is transversus thoracis muscle plain block, and I would wanted to convey to you that it is important that you know that all these blocks are available in the armamentarium of the anesthesiologist, and based upon the dermatome, myotome, and osteotome injury, the way the surgeon is going to do his surgical procedure, you will decide based on the other parameters of the patient. The patient is very sick. Thoracic paravertebral block can be an issue because in case if you produce a pneumothorax, it may produce it's a complication which the patient may not be able to take. So here you possibly go into either an erector spinae block or the other interfacial plain blocks which we measured. I just wanted to give a bird's eye view of the possible blocks that are available for us to work on patients with breast surgeries where maximum amount of research has taken place in relation to regional anesthesia, analgesia, breast surgeries, and outcome, not only in terms of pain relief, to decrease post-surgical pain, and to decrease the cancer recurrence and the microenvironment at the tumor cells. So it's very interesting, and I think more studies will come in the future. But the initial research started in regional anesthesia for breast surgeries, but now it has moved on to multiple other onco procedures. And this particular study was quadratus lumborum block. This is thoracic paravertebral block for gynecological procedures. And again, the reports say that QL blocks were better. And this was another study of the quadratus lumborum block versus epidural analgesia in patients undergoing radical cystectomy for bladder malignancies. And also, a lot of studies are going on in lower limb procedures, especially the commonest secondary seems to be in hip in geriatric patients coming with hip fractures, and in on-arrival blocks and like suprainguinal fascia iliaca, ping block, immediately alleviating the pain. And in osteosarcomas, once the amputation has taken place, phantom limb seems to be one of the real concerns in the modern practice, and there seems to be a huge role for using continuous catheters to prevent phantom limb pain after peripheral limb surgeries, commonly seen in lower limb surgeries, but also seen in upper limb surgeries. So with the advent of multiple catheters, the peripheral nerve catheters, all this has become a possibility. The incidence of phantom limb is on the decline when regional analgesia is used effectively in the perioperative period of surgical patients undergoing onco-surgeries. Before I conclude, I take the opportunity to welcome you all to the next national conference of ISA to be held between November 26th and 30th at Raipur. Thank you very much for your patient hearing, and would be happy to answer questions.
Excellent presentation, sir, as expected. As Dr. Rao has written, complete presentation. Sir, I had a question. Before doing regional in onco patients, do you insist on any particular investigations? Do you rule out metastasis of spine? Do you insist on any particular investigations before doing regional in onco case?
Madam, the only concerns will be patients having any form of coagulation disorders, if they are associated with malignancy, and whether they have any end-stage organ disorders like liver dysfunction and renal dysfunction. So all this is just to tailor-make. None of them are a contraindication to give regional, but it gives us an insight into the internal milieu and the dose of the drug that we use. Because interfacial plane blocks need higher volume, so we need to just tailor-make the concentrations, very site-specific blocks, very careful managing of which one you choose. So it gives us an insight, but I wouldn't say that irrespective of anything the patient's internal milieu is having because of the malignancy and because of the metastasis, still we can go ahead and plan an RA technique, the safest of the one among the given options. So because it's of its excellent pain relief, I think we need to embark on.
So even if the patient has spine metastasis, then would you prefer to avoid, or would you still go ahead?
Madam, spine, in metastasis, spine metastasis is very common in some of the primary tumors. The secondary are usually in the spine. But all the blocks that we describe now is definitely not a contraindication for when the patient has got a secondary in the spine matter.
Okay.
Madam, I see a question. Can we give spinal for a CA prostate with spine metastasis? Actually, it depends upon, number one, where the spine metastasis is clinically that is seen. And the only concerns will be you will not know, it's very osteoporotic. So once they have spine metastasis, it's very, very osteoporotic. So if you want to give spinal, my concerns are whether you will, in positioning the patient, whether you will produce any fracture that could happen because they're very osteoporotic. So that needs to be taken into consideration. But looking at multiple comorbids that patient may have, and if we think that regional and site-specific analgesia will be superior to giving them a general anesthesia, you can still prefer to go. It all depends upon the clinical scenario, the expertise of the anesthesiologist, which will be a combined decision with the surgeon. We can take a particular plan. So in end-stage disorders, it becomes very important that it's a collective decision that is taken to make sure that the best outcomes are given to the patient.
And one more question, sir. Do you need to take a separate consent for regional anesthesia, or does it come as a part of the general anesthesia consent?
Madam, ideally, the recommendation is we need to take a separate consent for regional anesthesia and analgesia, explaining to the patient what exactly you're going to do and the benefits of that. Because world over now, there are separate consent forms that have been developed for exclusively for regional anesthesia. So I would possibly recommend that we explain to our patients what we are going to do.
And would you prefer doing purely under regional, or do you always combine with GA?
Madam, regional, again, I said patient profile, surgeon requirement, all are important consideration. And even if we give general anesthesia, RA is given for the benefit, which I described earlier, in decreasing the intraoperative requirements and also as a pro-inflammatory,
As a
decreasing the pro-inflammatory mediators. I see a question about using, are we concerned only about osteoporotic fractures, or we are very concerned about when we give a spinal, whether we kind of promote the tumor cells entering inside. So when there are spine involvement, we definitely do not know microscopically what is going to happen. But here, probably it's already uh, it has metastasis and it has gone across the body. So whether this particular procedure enhances it versus the disadvantages of giving GA. So it needs to be considered before we take a call.
And in GA, is it, do you prefer TCI, TIVA, or full GA, or
Madam,
what?
actually now, if we ask um, once we start using target controlled infusion, we become an addict of target controlled infusion.
Yes.
And especially with monitoring the BIS scores, and you can titrate your anesthesia so very well that, because I consider that patients with malignancy or cachectic and they have sarcopenia. So we can even avoid muscle relaxants if need be. And we can go for TCI with the block, so that even giving a relaxant can be avoided. And it can be tailor-made in such a way that the recovery from the anesthesia is excellent. So that's why I think um, it's very, very good that all of us embark on the journey to learn exactly how to use a target controlled.
Yes. Yes, sir. Any other questions anybody has? Local infiltration in preventing recurrence and metastasis. There's one question in the chat box. What is your view on that?
Madam, what was that question? Infiltration of local anesthesia and?
To prevent recurrence, means to decrease the chances of recurrence and metastasis in future. Does it work?
Madam, I have not read anything related to that. I've read about several specific blocks, but not local infiltration to any particular area. I'm not sure of this answer.
And do you have any additives in your regional block, or
yes, madam. In all our regionals, we use additives, and additive of choice for me is dexamethasone, and more so in cancer patients. And the advantage is when you do a single shot block, the duration of analgesia lasts for close to 16 to 22 hours. And also it works very well in decreasing the postoperative nausea, vomiting. So even in a diabetic, I use dexamethasone as an adjuvant.
Okay. Thank you.
There is one question. Is it okay to give blocks for intubation in case of oral CA with neck dissection? Concern of needle passing through the disease to non-disease area.
So no, I think this question probably definitely when you're going to do it, I presume that they're asking a question of an awake intubation where you're using local infiltration. I would definitely not try to go into the tumor area and infiltrate, because the anatomy will be totally altered and it's very difficult to do the block like that. I would prefer to go for inhalational local anesthetic and then the spray and a mild sedation and go ahead and do the block, rather than using the airway blocks.
Sir, any comments on opioid-free anesthesia in onco surgery?
So again, there are a lot of literature saying that opioids produces angiogenesis and increase in recurrence and promoting tumor cell
Sir, your
migration.
voice is not clear, sir.
Madam, now?
No.
It is
Can you hear
okay.
me?
Yeah.
We can hear. Yeah.
Yeah. No. Actually, there are concerns about opioid use and angiogenesis and enhancing tumor regeneration, but not really sure whether it's all definitive or not. But yes, if it is going towards that direction, I think using regional anesthesia will definitely decrease the opioid requirements, and possibly this concern will be addressed too. Better to use lesser opioids and more of regional at this point of time.
Sir, I'm sure we would want to know a lot of things from you, and this discussion wouldn't end. But in view of less time,
Yes, ma'am. Yeah. We have
I
another.
thank you so much, sir, and wish you the very best for the coming year. And I'm sure you're going to take anesthesia to great heights.
Madam, all of us
Not only
together.
nationally, but internationally too, sir.
Madam, all of us together have to do it. We
So
will have
you're
to do
very
it together.
humble and very kind to us, but it is you who are going to do it. We are very sure of that. Thank you.
Thank you very much, madam. Thank you.
Thank you. Thank you so much, sir. Thank you so much for joining us.
Thank
We
you,
are really
madam.
Sir,
honored.
ISA Boruli entire support and cooperation for your terms.
Thank you, sir. Thank you so much. Thank you.
So thank
Thank
you
you, sir.
so much.
I would now ask Dr. Neelam to continue, please.
Thank you so much, Bala sir. And I second everything what Amola madam has said. So thank you so much again. So we move to our second topic of this webinar. The topic is perioperative considerations after systemic therapy for malignancy. And our speaker is Dr. Divatia, sir. Divatia sir is head critical care at Lilavati Hospital and Research Center, Mumbai. He is past president of Indian Society of Anesthesiologists. He is editor-in-chief for Airway. He is past president Society of Onco-Anaesthesia and Perioperative Care. Sir is past editor-in-chief for IJA, past president IDA. Sir is past president Indian Society of Critical Care and Medicine. Sir has over 205 publications in national and international journals. His topic is perioperative considerations after systemic therapy for malignancy. And to moderate this session is our own Dr. Rajiv Garud. Sorry, I don't have his CV slide. But Garud sir is Vice President of ISA Borivali. Sir is Senior Private Consultant with more than 30 years of experience in difficult and high-risk cases. Over to you, Garud sir.
Good evening, everybody. I request my colleague and immediate past president, Dr. Jigishu Divetia, to enlighten us on his topic. Dr. Divetia, please.
Good evening. So thank you very much for inviting me to speak over here at this meeting of the ISA Borivali. I am very happy and relieved that I am able to finally attend one of the academic sessions conducted by ISA Borivali. Dr. Rao had been after me many times, and unfortunately, because of so many other prior commitments, I have had to sort of disappoint you. So I'm very happy to be here. And let me start by giving my best wishes to Dr. Bala Venkat for his term as president. He's got lots of ideas, lots of vision, and I'm sure he'll take the society forward. And of course, we are all going to be there to back him. So I hope you can see my slides. Can you
Yes,
see?
sir. Yes, sir, we can see.
So I'm going to speak about anesthesia after systemic cancer therapy. And this is a very important topic nowadays. We all know that, cancer is a second leading cause of death worldwide. And the most important thing is that almost 80% of cancer patients are likely to require surgery, either for a diagnostic procedure or for a therapeutic procedure or for a palliative procedure, right? So almost most cancer patients will come up for surgery. And because we are now aware of so many intricacies of the cancer patient, especially with respect to the perioperative period, that a specialty of onco-anesthesiology has sort of emerged. And there is also now a DM in onco-anesthesia, which is now been recognized by the National Medical Commission. So now we've started getting registering candidates for DM onco-anesthesia. Right? There's already been a DRNB in onco-anesthesia, and now there's also a DM in onco-anesthesia. So onco-anesthesiology is a practice and study of perioperative management that can help to positively influence surgical and oncological outcomes. And Dr. Bala Venkat referred to that in his talk about the role of regional anesthesia in improving oncological outcomes. But onco-anesthesia encompasses many, many things. One is, of course, what we call as prehabilitation, which includes, medical optimization and getting the patient ready for major surgery. Whether anesthetic technique can reduce cancer recurrence and metastasis. So this has been a hot topic. And a lot of animal and laboratory models which suggested that, inhalation anesthetics, and also some anesthetics like ketamine and thiopentone could actually depress immunity or different organ systems. Opioids could promote angiogenesis, reduce NK selectivity, and therefore lead to cancer recurrence and metastasis in animal models and laboratory models and cell lines. And that's what, and if that was true, then modification of the anesthetic technique to minimize opioids, and therefore the concept of opioid-free anesthesia, and also in total intravenous anesthesia may, as opposed to inhalation anesthesia. However, so far the randomized control trials which have been done, and there have been 2 or 3 published trials. The largest randomized control trial which was published compared paravertebral block with propofol sedation versus standard in general anesthesia with sevoflurane and opioids. 2,000 patients, 1,000 in each arm, roughly, and found absolutely no difference in outcome as far as cancer recurrence and metastasis was concerned. This was in breast cancer. There was a similar smaller study of about 200 odd patients in colon cancer. So although the experimental evidence the experimental data seems to be tempting, as of now, the randomized controlled trials have not yet given us that information. Having said that, there are many other randomized trials which are ongoing, and and we may get some answer as to whether we can avoiding inhaled anesthetics or minimizing the use of opioids, whether that reduces cancer recurrence and metastasis. But as of now, we don't have direct good randomized controlled trial evidence to do that. In spite of that, if you introduce regional anesthesia, ensure early recovery from surgery, the aim of the perioperative management should be that, the patient is ready for the next round of oncological therapy, what we call as return to intended oncological therapy, which is often chemotherapy, can be radiotherapy, right? We should also want to prevent chronic post-surgical pain, and of course, wherever required, supportive care, rehab, and palliative care. So all that is under the scope of onco-anesthesia. Now, when you look at a patient who comes up for cancer surgery, there are many, many considerations, but in this talk, we'll just focus on the effects of chemotherapy and what we now are not just chemotherapy agents. We've got biologicals, we've got monoclonal antibodies, we've got immunotherapy, all that what we call as targeted therapy. And all of these have effects that all anesthesiologists should be aware about. Okay? So when we say therapy for cancer, they could have prior therapy, surgery, they could have chemo, radiation therapy, hormonal therapy, targeted therapies. And like I said, targeted therapy has small molecules and many of them end in nib, right? So geftinib, crizotinib, and they are of use for lung cancer, they use for renal cancers, they use for myelomas, many other sort of and monoclonal antibodies which end in a mAb. So, they are used. So like, for example, cetuximab, which is commonly used in head and neck cancer, trastuzumab, which is commonly used in breast cancer, rituximab for lymphoma, nivolumab and pembrolizumab for lung, esophageal, and many other cancers. So then, and the problem is that these new molecules, or what the targeted therapy, are increasing by leaps and bounds. The amount of cancer research, every time a new mutation is found and a drug is developed which targets that mutation in cancer cells, and therefore there are specific subsets of cancer cells which can be targeted. And every week or every month, there's a new mAb or a new nib which comes up, and we have to be aware of some of these things and maybe even talk to the oncologist to find out what that drug is all about. Okay. So now, when I started my career in Tata Memorial Hospital about 35 years ago, many patients came up for primary surgery without any prior systemic treatment. But today, I think there are very few tumors for which surgery is done per primum. For a vast number of cancers, patients would have received some form of systemic therapy, usually chemotherapy, sometimes radiation, sometimes a combination of chemotherapy and radiotherapy, and some targeted treatment or hormonal treatment, and followed by cancer surgery. So that is what we call as neoadjuvant therapies. That is before the surgery. Many patients after the primary surgery will have additional chemotherapy or radiation, and they may need it. And then sometimes they may have a recurrence and they'll get some further chemotherapy after that, or they may have metastasis and they may have come up after that. And many of these patients, especially breast cancer patients, they survive long periods of time. The cure rates for breast cancer are excellent. It is not surprising to find patients surviving 5, 10, 15, 20, 25 years after breast cancer surgery and some other kinds of surgery. And so the cumulative effects of chemotherapy agents they may have received over the years also need to be considered. So you need to consider this in patients who come up for surgery for a recurrence, or who come for an incidental surgery. Someone may come up for intestinal obstruction or an appendicectomy, and you might have to treat those patients. And because many of the cancers have very good outcomes, and especially childhood cancers, the leukemias, the childhood leukemias, they survive for a long time, and you can get patients coming up for surgery many years after cancer therapy. They may even come up for second cancers and so on. Okay? So it is important to understand or know what are the effects of some of these systemic treatments which are used for cancer. So let me just start with a case. This is a breast cancer patient who was treated more than 2 years ago, and now she has presented with cancer of the other breast. And in the course of a previous treatment for breast cancer, she had received neoadjuvant, so before the primary surgery that she underwent the last time, a schedule called AC, that's adriamycin and cyclophosphamide. And the total cumulative dose of adriamycin was 400 milligram per square meter. She'd also received radiotherapy to the left breast. She also had received paclitaxel as a post-operative, that says adjuvant treatment, and trastuzumab, which is a monoclonal antibody. Okay, and she otherwise seems to be quite well. But all these drugs which she received, especially adriamycin, trastuzumab, and paclitaxel, have important considerations for us, and mainly cardiotoxicity. Okay? And many drugs in breast cancer and many other cancers are cardiotoxic. And the big one here are the anthracyclines, that's doxorubicin or adriamycin, epirubicin slightly less. The monoclonal antibodies, that is trastuzumab, goes by the trade name Herceptin. Okay, and some of these other drugs like 5-FU, like 5-fluorouracil, okay, cyclophosphamide, and radiation to the left chest, okay, because it affects the heart. So so you have to be aware that these treatments can cause cardiotoxicity. Now, so cancer therapy related cardiac toxicity is not uncommon, and you need to be aware of these sort of things. And it can be simple things like hypertension, arrhythmias, to myocarditis of immune checkpoint inhibitors, and heart failure with adriamycin. So you can get different varieties of cardiovascular toxicity, including hypertension and embolism, thrombosis, and embolism. But what we are really worried about is damage to the myocyte, the heart cells, which leads to heart failure. And here you have things like anthracyclines, that is doxorubicin, and trastuzumab, which are the major culprits. Okay. So what is the incidence of left ventricular dysfunction after chemotherapy? So if you give adriamycin, almost 25% of patients will have are likely to have cardiac dysfunction. Cyclophosphamide can also do that. The others are not very common, are not as common, but like it can exist. But adriamycin is the big drug, and as the cumulative dose of adriamycin increases, as the number of cycles increases, the chance of developing chronic cardiotoxicity keeps on increasing. Okay? And the cutoff is around, it's at about 400, it starts going up at 400 milligrams per square meter. Once the dose starts exceeding that, the incidence of chronic cardiotoxicity goes on increasing. And right, so you need to also know from your history, what was the total dose of adriamycin this patient has received. Okay. Now, the thing about adriamycin, and this is something which is very important, is that even after you stopped adriamycin, after the course of chemotherapy is over, it's completed, myocyte cardiac cell damage can continue, and this can also be progressive. So it can be progressive, of course, very slowly, but it is progressive and it is not reversible. So you can't say, I've given adriamycin, but the adriamycin was stopped 2 years back, so now I don't think there's any problem. In fact, if it's 2 years back, there is a danger that there might have been further worsening after the last echocardiogram, which the patient may have done after the completion of chemotherapy. There might be no worsening of heart function, and need to be very, very aware of that possibility with adriamycin. So it is progressive and it is irreversible. Once the damage has taken place, these myocytes are not going to recover. Right? And that is a problem with anthracycline. Now, of the targeted therapy agents, so trastuzumab or Herceptin also is cardiotoxic, and that also causes left ventricular dysfunction. And again, a similar sort of incidence, almost 1/4 of patients can get cardiac toxicity with Herceptin. A drug called Avastin or bevacizumab, okay, is also cardiotoxic, but much less common. And here the main thing is hypertension and thrombosis. Okay, there are others which cause, especially imatinib, which is given for some of the hematological malignancies, chronic myeloid leukemia, and sometimes for gastric cancers, but again, less common. But this is extremely common, Herceptin, right? And Herceptin is given for patients who express the HER2 new receptor. So you will say the oncologist saying is this patient is HER2 new positive, and this patient is likely to be on Herceptin. It is expensive, but there are generic molecules which are now available, which makes it much cheaper, and more patients are going to be taking trastuzumab. Now, the important thing is when you combine it with anthracyclines or with paclitaxel, the incidence of cardiotoxicity is higher. Of course, if your patient is older, you have borderline pre-existing cardiac disease, it's worse. Okay, but the important thing about trastuzumab is this toxicity is reversible. So if you stop the trastuzumab, the cardiac function will recover. Okay. On the other hand, as opposed to anthracycline, adriamycin, if you the cardiac damage continues even after you stop the drug. So this is the important difference between trastuzumab cardiotoxicity and the anthracycline cardiotoxicity. There are some agents like 5-FU, fluorouracil, which cause coronary artery vasospasm, and it mimics myocardial ischemia. Just need to be careful when you look at some of these drugs. Okay, you can get acute cardiac toxicity in the form of hypersensitivity reactions, arrhythmias, hypotension, and myocarditis, pericarditis, but we are more concerned, but this is more the concern of the oncologist when they treat the patients when they're giving the infusion. We are not so likely to be involved unless you get called as part of a code blue team or something like that. Okay. Now, although radiation is not systemic therapy, I'm mentioning this because it's sometimes given, and especially if it's given to the left side of the chest, you can get, thrombosis of the endarteritis of the coronary arteries, and it can get accelerated atherosclerosis and fibrin deposition and pericarditis. With improved radiation therapy protocols, this is getting less and less. Okay, but if the patient has had treatment, say 15 years ago or 20 years ago, this is a possibility. Okay, so now this is a very important paper, which I think anyone who's treating patients with cancer should read. It's an issue on cardio-oncology, and it's from the European Heart Journal in 2022. And essentially, this is cancer therapy-related cardiac dysfunction, that's CTR-CD. Now, if it's symptomatic, it's not a big problem. You have symptoms and you're going to look out for it, right? You're going to do something about it because the patient is going to complain, or you're going to elicit a history of exertional dyspnea or some symptoms of heart failure. And of course, it can be mild, moderate, or severe, but very important is this cardiac dysfunction can be asymptomatic for a very long period of time. The only way to know whether the patient has cardiac dysfunction or not is by some sort of investigation. And the commonest and the simplest investigation is echocardiography. And if you have LVF, which is more than 50%, you're okay. Okay. And even if your LVF is 50% or higher, it appears normal. Nowadays, in the echo, they do a parameter. They have a parameter called global longitudinal strain, or GLS. Okay. If that has gone down by 15% from baseline, or there is a high increase in troponins, then this patient has mild asymptomatic cardiac dysfunction. Okay. And if your LVEF drops below 50%, right, or the global longitudinal strain drops, or the biomarkers are increased, and this patient has cardiovascular dysfunction, even though the patient is asymptomatic, right? So if you read the AHA guidelines for heart disease, for assessment of the patient with cardiac ischemic heart disease or with cardiac disease for non-cardiac surgery, they are very, very conservative in the use of echocardiography. And, they, by and large, in many patients, they do not recommend echocardiography. But these European Society of Cardiology guidelines for patients with cancer, okay, they say that, you need to understand in patients undergoing oncological surgery, the complications, cardiac complications are determined by the patient-related risk factors. So patients with pre-existing cardiovascular disease, the type of tumor, therapies, for example, the anthracyclines, and the expected surgical risk, right? And you should consult a cardiologist in patients who have symptomatic or asymptomatic cardiovascular disease at high risk of cardiovascular toxicity risk, when the patient is also going to have post-op chemotherapy, and in patients receive pre-op or neoadjuvant chemotherapy. And essentially what they say that if the patient has received more than or equal to 250 milligram per square meter of and doxorubicin, that's adriamycin or equivalent, you should consider echocardiography and troponins in moderate risk patients, and may be considered in low risk patients. So a little liberal recommendation for a cardiac evaluation, which will include, of course, an ECG, an echo, and maybe even the measurement of troponins. Okay. And measurement of pro-BNP, that's natriuretic peptide, and or a cardiac troponin, is recommended in patients if they're going to be used for monitoring in the post-op period or during treatment. Okay. And you should continue this within 3 months after completion of chemotherapy. You should also do this. And they also recommend long-term surveillance in asymptomatic patients, especially if they receive adriamycin. Okay, so they say you should do a thoracic echocardiography every 5 years in adults, every 2 years in adults who are childhood survivors. Okay, and if they received cardiotoxic cancer therapy, then at 1, 3, and 5 years, and every 5 years thereafter, because these patients can have progressive cardiac dysfunction. So if you get a patient, just because she's had chemotherapy 2 years ago, don't assume everything's fine, everything's gone back to normal. In fact, things could have got slightly worse. And then, of course, you need to take care to manage the patient as if he was a high cardiovascular risk patient, which I won't be going into. But these patients will present as heart failure patients, and they will be treated as heart failure. So now this is a young man who had metastatic testicular cancer at the age of 25. Okay. And many of will have heard of athletes like Lance Armstrong, who is a survivor of metastatic testicular cancer. In cricketer Yuvraj Singh has had this. So they are public figures who are survivors of testicular cancer. So these patients survive excellent response to chemotherapy, survive long, they almost have normal lives. Okay. But if they've received a drug called bleomycin for the chemotherapy, right? In the regimen is called BEP, that's bleomycin, etoposide, and platinum, that's cisplatin. Okay. They live well, and bleomycin is a lung toxic agent. It's a pulmonotoxic agent. Now, let's say this patient comes for knee arthroplasty, right? And now he has been complaining of shortness of breath. Otherwise, he's healthy, but he's got crackles in the lung. And this patient probably has bleomycin-induced pulmonary fibrosis. So this is what you need to be aware of. Okay. So it can happen in up to 30% of patients, and so you need to be aware of long-term incidence of pulmonary fibrosis with bleomycin. So if you had a patient who comes up with history of having taken bleomycin, and bleomycin now is most commonly used for testicular cancer. Okay. And even if you've got metastatic cancer, they respond brilliantly to chemotherapy. So, they do survive very well. But so if they do come up, you need to do at least a chest X-ray. You need to do pulmonary function tests. And in the pulmonary function tests, the diffusing capacity for carbon monoxide, which tells you about the diffusing capacity of the lung, is what will tell you whether the patient has got significant derangement of pulmonary function or not. Okay. Now, if the patient has taken bleomycin and if there is lung toxicity, there is not much great evidence, but in the past, we used to believe that a high FiO2 and a high positive fluid balance make the pulmonary fibrosis worse and get the outcomes worse, and you can even get an ARDS post-op, right? So the idea would be to give the minimum FiO2, which could even be as low as 21%, which maintains the oxygen saturation above 94%. So don't try to push for 100% SpO2 on your pulse oximeter. Give as low an FiO2 and try and give as little fluid as possible. That doesn't mean if the patient is hypovolemic, you don't give fluid, but give as little fluid as is required. Give PEEP intraoperative to maintain oxygenation. And of course, the usual respiratory therapy and physiotherapy to keep the lungs open. Okay? And monitor patients closely in the intraop and post-op period. Again, radiotherapy to the chest also causes radiation pneumonitis in the acute phase and pulmonary fibrosis in the chronic phase. And that can go on to respiratory failure and chronic cor pulmonale. And again, that may be related to the total dose. More than 20 grays is what they do. Concomitant chemotherapy, like especially some pulmotoxic agents. So, and the amount of lung which has been radiated. So if you've got concomitant radiation as well as chemotherapy, then again, that can complicate matters as far as the lung treatment is concerned. So bleomycin, please keep in mind lung toxicity, do a PFT, including a DLCO, give minimum FiO2, give as little fluid as required, give intraoperative PEEP, and give good chest physiotherapy for these patients. This is another patient who's had ovarian cancer. She's completed chemotherapy with cisplatin 5 weeks ago. Now she's scheduled for tumor reduction. And this is a very, very common scenario. Patients with ovarian cancer by and large, respond quite well to chemotherapy. They will invariably have had neoadjuvant chemotherapy. Cisplatinum will always be there. They may also be paclitaxel or some other agent which may be cardiotoxic. And they will come for tumor reduction after that. Okay. So she seems to be okay otherwise, but which test would you want to do now? See, a CBC with differential is common for all chemotherapy, post-chemotherapy, because it depresses the bone marrow, and some patients are operated within 3 weeks after chemotherapy. So you should always do a CBC in all patients receiving any chemotherapy and make sure the hemoglobin and the white cell and platelets are not in a low range. Okay. But apart from that, liver function tests, electrolytes, renal function tests, and coagulation tests. But considering this patient received cisplatinum, you must do renal function tests. Okay, so cisplatinum causes renal damage, and you get necrosis of the proximal and distal tubules and collecting ducts, reduced creatinine clearance. You'll get hypokalemia and hypomagnesemia because they just get they cannot be retained in the tubules, and you get hypomagnesemia and hypokalemia. Okay, and creatinine may be raised, but you need to worry about cisplatinum. And in these patients, if there is a further renal insult during the perioperative period, for example, by bleeding or by hypovolemia or by other drugs which someone may give, like for example, diclofenac or one of the NSAIDs or something, you need to be careful about these sort of drugs in these patients. Not to say that they are contraindicated, but you have to be careful and monitor the renal function in these patients. Some patients may present with obstructive uropathy. They're usually advanced cases of CA cervix or pelvic tumors. Okay, but cisplatinum you need to worry about in all these sort of things. Okay, so the cisplatinum and carboplatin, it will be slightly less nephrotoxic. The nephrotoxic is dose limiting, so it won't be chronic and progressive, but it may be there. Okay, others cause some different types of nephrotoxicity, like methotrexate. Cyclophosphamide causes hemorrhagic cystitis, but I mean, it's okay. Now, some patients, like I said, will have prolonged continuation of the side effects of pulmonary function after chemotherapy. The effect of pulmonary function at 5 years is, reduced with bleomycin, because nowadays the oncologists will often reduce bleomycin or stop bleomycin if they find pulmonary toxicity is occurring, and then the toxicity doesn't progress much further. Okay. And now regimens, even eliminating bleomycin, are available for testicular cancer. Now, as far as drugs on the peripheral and the central nervous system are concerned, there's one drug which you need to be careful about, vincristine. Vincristine causes a peripheral neuropathy. Okay. And I once had a patient who had received vincristine for one of his, I think he had for a lymphoma. He'd had vincristine, I think, for a Hodgkin's lymphoma, and he came again, I think, for a staging laparotomy, or he came for some sort of procedure after that. We gave succinylcholine, and then this patient had massive hyperkalemia. He had a cardiac arrest on table. He was revived, and everything went off okay. But the reason why this patient had hyperkalemia after succinylcholine was because vincristine caused the peripheral neuropathy. And if you have read the problems with succinylcholine, I know many people don't use it nowadays, but when I trained, it used to be a question you have to answer pit-pat in your exam if you wanted to know what are the problems with succinylcholine, hyperkalemia, in which condition is hyperkalemia, 1, 2, 3, 4, 5, and one of them used to be peripheral neuropathy, lower motor neuron disease, peripheral neuropathy. So even with cisplatinum, you can get peripheral neuropathy, and so just be careful in all these patients. Especially even if you're considering regional anesthesia, peripheral nerve blocks, if patients have received some of these drugs, ask for that history of any nerve signs in these patients. And if they do have some neurological symptoms, then you weigh the risks and benefit and decide whether you want to go ahead with a peripheral nerve block or not in some of these patients, or for that matter, a neuraxial block. Okay, so evaluate all these patients very well, and regional may be a relative contraindication, but as we discussed earlier, you weigh the risk versus the benefit. So this is a nice diagram of, we call it chemotox man, so these are, but the C is for cisplatin. It can cause neurological and damage. C can cause renal damage. B can cause lung damage. D, this is the heart, is by doxorubicin, cardiotoxic, and so on. Okay, so it's a nice V for peripheral neuropathy. So this is a chemotox man. Just a nice way to summarize what I've been talking of for the last so many times. Okay, so I think it's important that we understand the problems with chemotherapy. Please talk to your oncologist, because some of the drugs are very new, and even though I've been practicing onco-anesthesia for 35 years, I may not have heard of some of the drugs. Best to pick up the phone or look up your smartphone and see what are the potential side effects of many of these drugs. Yeah, so thank you very much for listening.
Thank you very much, Dr. Divetia. It was really a wonderful talk, and a lot of things which we were not aware of, we came to know today. So thank you very much. Questions, I can read one question that, sir, can you highlight on HIPEC chemo intraoperatively to reduce recurrence and micrometastasis?
Yeah, so HIPEC is a procedure which is undertaken by the surgeons in patients with extensive peritoneal malignancy. So either a CA stomach or a CA ovary which has involved the peritoneum, or it's pseudomyxoma, or peritoneum. So here what the surgeons will do is first will do what is called a cytoreductive surgery, which means they'll try and remove as much disease as possible. So they'll chop off virtually half your abdomen. They might resect your ovaries, your colon, the stomach. They'll take out the omentum, they'll take out the peritoneum. And then because there had been peritoneal seedlings and so on, they will infuse chemotherapy into the peritoneum. So HIPEC stands for heated peritoneal chemotherapy. Okay, and so at 40 degrees, they will infuse the chemotherapy agent is prepared in dextrose or some other solution, and it is infused at 40 degrees centigrade into the peritoneal cavity. It's kept there for some time and then it is drained out. And the idea is that this local chemotherapy will also, take care of all the peritoneal seedlings and so on. Now, when you give heated chemotherapy, you're giving a heated solution and also giving chemotherapy. Some of the chemotherapy is absorbed. One of the common drugs used is cisplatin, so watch for renal function. The other thing is there is a massive inflammatory response which can happen in the immediate post-op period, even intra-op during the chemotherapy because of the high temperature. And therefore, you have to maintain the temperature normal. You have to, before the chemotherapy infusion begins, you have to cool the patient down. You have to pack ice. I mean, all those maneuvers you have to do to maintain the temperature. But that is becoming increasingly common now. And earlier it was experimental, but now it's become quite common for surgeons to do this in case of peritoneal malignancies or malignancy of some of the solid organs involving the peritoneum. That is soma peritoneum.
Thank you, Dr. Divetia. One question is, with hypercoagulable state, should we start LMWH in all patients?
Yes, so cancer is a hypercoagulable state, and in all patients, we should start thromboprophylaxis. If there has been a lot of bleeding and there is oozing and all, maybe you can withhold for the first day or so, but you must give thromboprophylaxis in the form of mechanical thromboprophylaxis with calf compression, intermittent calf compression devices. And definitely after you're sure that your hemostasis has been achieved, you should start low molecular weight heparin in all your patients. So I think in some would start even pre-operatively and some would start definitely in the post-operative period. So thromboprophylaxis is essential in cancer patients.
Okay, so with this, we conclude this topic from ISA Borivali. We all thank you very much, Dr. Tivaria. And over to Dr. Neelam for next topic.
One more question, sir.
Yeah.
Yes, sir. Sir, so going by your lecture, most of us are doing a lot of onco cases are on the rise, and many patients with neoadjuvant chemotherapy are coming. So, is it absolutely must that we should know about all these drugs which are given for chemoprophylaxis or chemotherapy, and then have a discussion with the treating medical oncologist regarding the plan of anesthesia?
Yeah, so I mean, you need to know the side effects of many of these drugs. Like I said, the common ones I've already highlighted. So, I mean, you need not discuss the plan of anesthesia with your oncologist, but you should, if there's some drug which is new or some drug which you've not heard of, you can always ask what is it, look up what are the potential toxicities, and especially if they affect the heart, lung, or kidneys, you need to be aware of that. So, because especially you have to a lot of patients do breast cancer surgery. So I mean, the breast cancer surgery is very common, and so you need to be definitely aware of these agents which have been used.
Thank you, sir. Thank you very much.
Thank you.
Devatia sir, it is always pleasure to listen to you. We just don't want the lecture to end. Thank you so much. We move on to our next topic. Our next topic is pediatric onco-anesthesia, and speaker for this is our own Dr. Indrani Hemant Kumar Madam. Madam is Professor of Pediatric Anesthesia, ex-professor and head of Department of Anesthesiology at CGS Medical College and KM Hospital, Mumbai. She has more than 31 years of experience. She is first rank holder in DA and MD Anesthesia from Mumbai University. Madam has more than 80 publications to her credit, along with multiple orations such as Dr. Tambe oration, ISA Nasik oration, J. Sambadikar oration. Madam is President RSACP National, ISA Governing Council member, past President ISA Mumbai. Madam has various awards such as ISA President Appreciation Award, Bharat Jyoti Award, Natya Kalaimani Award from Tamil Nadu government. Madam is going to talk on pediatric onco-anesthesia. And to moderate this session is our own Dr. Shilpa Tivaskar Madam. Madam is a governing council member of Society of Anesthesiologists, ISA, that is Maharashtra chapter. She's senior consultant at Bhaktivedanta Hospital and Research Center. Madam is founder member of ISA Borivali City branch and MC member of IMA Mumbai West. She has multiple awards and publications to her credit. Over to you, Shilpa Madam.
Yeah, welcome Dr. Indrani Hemant Kumar Madam, our national GC. Madam is a teacher which everyone likes and waits to hear. Madam takes the topic so much nicely and in detail that you need not read any textbook, any internet discussion. That's it. You are done with the topic if Madam teaches it. Welcome, Madam. We are really blessed to hear from you.
Thank you, Neelam and Shilpa, for that introduction. Let me first share. Can everyone see the slides?
Yes, Madam.
Okay. Respected Dr. Bala Venkat, National President, immediate past President and Academic Chair, my mentor, Dr. Devatia, Dr. SAM's office bearers, Dr. Anita Nehte, Saurabh Bharde, Rajesh Tagadpalle, and Avinash Bhosle, and Borivali Society of Anesthesia office bearers, Dr. Amola Parekh, President, Neelam Nalge, Vice President, my friend and my partner in crime during our residency, Dr. Rajesh Rao, Dr. Shilpa Tivaskar, the chair of this session, Dr. Ritesh Gupta, the only surgeon in this webinar. Thank you all very much for inviting me to speak among these stalwarts. And today I will be speaking on pediatric onco-anesthesia. Care of infants and children, especially while giving anesthesia, requires a heightened emphasis on the physiological changes that occur during development and requires a different perioperative approach than adults. So, what's about childhood cancers? As Dr. Divati already said, childhood cancers are not many. The impact on children with cancers can be related to the direct effects of the tumor and the effects of treatment. We will be going in detail on this. The adverse effects of chemotherapy and radiotherapy can have a long and short-term detrimental effects. And it is common for children with cancer to require frequent anesthesia at different stages from the beginning of their cancer diagnosis, during treatment, and even during follow-up in the OR or outside the OR. If you look at the distribution, the major cancers are the hematological cancers. One good thing is they have a very good survival rate. Leukemia, lymphoma, and CNS tumors are the most common. And of course, we can have others like soft tissue sarcoma, sympathetic nervous system tumors, renal tumors, melanomas, and others. So, what are the predisposing factors? Most of the time, you can look at the genetic factor. It could be because of some syndrome and or a bone marrow failure. Hereditary factors are very commonly seen in Wilms tumor and retinoblastoma. And of course, environmental factors because of radiation and toxins, especially the chemotherapeutic toxins. So if you look at the age association with specific malignancies, you will find a higher incidence of CNS tumors, Wilms, leukemia, and neuroblastoma in young age group, and lymphomas and bone tumors in the older age group. So what is the effect on long-term survivors? Dr. Jiggy already spoke of a second malignancy. So what happens? Most of the time, it's the radiation and the chemotherapy, which is recognized as a possible cause. Radiation, much of what we know about the health effects of radiation has come from the survivors of the atom bomb, which we saw in Japan, and some types of chemotherapeutic agents like alkylating agents like chlorambucil, cyclophosphamide, busulfan, and platins as like cisplatin or carboplatin, and anthracycline inhibitors like etoposide. They are the ones who can produce a second malignancy in these patients. And of course, adverse effects of radio and chemotherapy. Then the effect can be on their growth and development, and also on the CNS function. New cranial radiotherapy is known to have adverse effects on intelligence, radiation-induced cognitive decline. It can be so devastating that some of the young children under 3 or 5 years, in the mid 80s and 90s, when, we didn't have very good chemotherapeutic agents, the families actually opted out from these therapies. Such has been the kind of cognitive decline in these babies who undergo this chemotherapy. Cardiac, renal, and pulmonary toxicity, we already heard. Again, reproductive function. It includes an increased risk of pubertal failure, premature, menopause, sexual dysfunction, and infertility. And of course, psychosocial effects. It can be so damaging to the child that, the child can report anxiety, depression, and post-traumatic stress disorders. So the general principles of treatment is a multimodal approach. So the child comes for a biopsy or a definitive diagnosis prior to therapy, in which immunophenotyping and cytogenetics are especially used in hematological cancers. The conventional cytogenetics, immunotyping, and real-time PCR, actually they aid in identifying the specific clones in characterizing the hematological malignancies, prognosticating and assessing the minimal residual status of the child at that point of time. Staging, of course, stage 0, 1, 2, 3, and 4. We have all learned stage 0 being abnormal cells that have not spread. Stage 1 being tumor contained within that area. 2 is a tumor has grown larger and possibly spread to nearby lymph nodes. 3 is when it has spread to the distant lymph nodes. And 4 is cancer has spread to the other tissues and distant areas of the body. We also know of TNM classification, that is for solid tumors, and the other therapy, generally the multimodal, approach would be a combination of chemotherapy, radiotherapy, and surgery, all helpful in better resection. The chemotherapy and radiotherapy aids in better resection in some. So, what is the role of anesthesiologists? Anesthesia required at all stages of their care, including diagnosis, treatment, tumor surveillance, and pain management. So, anesthetists are required. A knowledge of physiological effects of the malignant process and its treatment are vital. So, coming to leukemia, it's about 1/3 of the childhood cancers. 80% is acute lymphoblastic leukemia, and it has 85% success. Peak occurrence is by 2 to 3 years of age. 10 to 20 fold increase is seen in Down syndrome, and multi-agent chemotherapy is given based on presenting age, white blood cell count, and the presence of extramedullary disease, immunophenotype, and cytogenetics. Lymphoma is the next common one. Non-Hodgkin's lymphoma is more common in young childhood. 2/3 of Hodgkin's lymphoma is diagnosed between 10 and 14 years old. And the mainstay of treatment for lymphoma is chemotherapy, but radiotherapy and surgical resection may also be used. Lymphoma compressing on the mediastinal structures can be so devastating and so dangerous, and it could be one of the challenges for all anesthesiologists. Brain and CNS tumors can be malignant and non-malignant. Astrocytoma is very common, followed by glioma, and it is treated with a combination of surgery, chemotherapy, and radiotherapy. Embryonal tumors are the next, which are quite common in children. They arise due to proliferation of tissues, normally only seen in the developing embryo. Medulloblastoma, neuroblastoma, retinoblastoma, nephroblastoma, hepatoblastoma are some of the examples which you can see. Around 6% of the childhood cancers are renal tumors, and nephroblastoma accounts for about 90%. In our hospital, the major cancer surgery which we do is nephroblastoma. If you can see, the nephroblastomas can grow so big. It can, push the diaphragm, and it can cause an increase in intra-abdominal pressure. What is so unique about neuroblastoma is it can even cross the midline. Wilms tumors, as I said, can be very massive, and it can reduce the functional residual capacity of the child. The other tumors, bone cancers, soft tissue sarcomas, germ cells, and gonadal tumors are also can be seen in the pediatric age group. So what are the challenges? Challenges can be because of the cancer itself, or it can be because of the treatment the child has received. So one example which I would want to talk about is the presence of mediastinal mass. The challenge is due to the proximity of this mass near the airway, heart, and the great vessels. It can cause compression. It can cause involvement of all the nearby anatomical structures, and it can be manifested as cough, stridor, dyspnea, orthopnea, SVC syndrome, and Horner syndrome. The most common mediastinal mass which we see in our practice is Hodgkin's lymphoma, non-Hodgkin's lymphoma, and ALL. All of them are known to cause mediastinal involvement. The other challenge because of cancer is a raised intracranial pressure. Increased intracranial pressure may present acutely or develop insidiously, secondary to obstruction to the flow of CSF, infection, bleeding, or mass effect from the tumor. So it can result in a low GCS in the patient. Patient will really be obtunded. Brain metastases are far less common in children. Common signs and symptoms in these children are change in vision, nausea, vomiting, and a younger child may be inconsolable, restless, and irritable, and an older child may complain of headache. The other cancer-related problem which we face is an electrolyte imbalance. tumor lysis syndrome is an important primary cause of, and is an oncological emergency. Tumor lysis syndrome occurs when rapidly dividing large volume tumors such as highly aggressive lymphomas and acute leukemias are treated with cytotoxic agents. So there is massive lysis of lymphoblastic cells, which releases intracellular metabolites such as potassium. If you look at this chart, it can release potassium and then, into the systemic circulation. The child can present with hyperkalemia, hyperuricemia, hyperphosphatemia, and secondary hypocalcemia because of hyperphosphatemia. All this electrolyte imbalance can lead to cardiac arrhythmias, seizures, renal impairment, and even mortality. It's commonly seen in ALL patients. Remember, especially in these patients with electrolyte imbalance, in ALL especially, injection dexamethasone as an antiemetic should not be given because it is known to cause tumor lysis syndrome. It has got lympholytic properties and therefore it hastens the tumor lysis syndrome. The other secondary causes of electrolyte imbalance could be because of hormonal dysregulation, dehydration, and sepsis. SIADH is an example of hormonal dysregulation that causes hyponatremia. Any primary brain cancer and lymphoma can cause SIADH, leading to seizures and encephalopathy. The other challenge you can see is coagulopathy. Cytokines, procoagulant, and fibrinolytic proteins are released by the cancer cells. The prothrombotic state causes increased risk of thrombosis and bleeding. And usage of procoagulant medications, long-term access catheters, chemotherapy, radiotherapy, surgery, all of them can cause hematological dysfunction. Remember, irradiated blood are reserved for children with Hodgkin's lymphoma. Again, tumor infiltration occurs in the bone marrow and platelet sequestration in the spleen in AML and ALL. Neutropenia occurs due to abnormal maturation and dysregulated proliferative immature cells and following chemotherapy. So these are the patients who are, following chemotherapy can develop myelodysplastic syndrome consisting of anemia, neutropenia, and thrombocytopenia. And when they develop a platelet of less than 40,000, it demands a platelet transfusion. They are very susceptible to infection because of the neutropenia, and they can present as fever, pain, and chills. Again, this is a medical emergency and it has to be treated with IV antibiotics. Children can present with anemia, which is common symptom of all pediatric cancers, and that leads to poor feeding, malaise, tachypnea, and dizziness. So what are the challenges due to the treatment? We saw the challenges due to the cancer itself. Now, these are some challenges which we find because of the treatment. So first is chemotherapy. We heard in detail about chemotherapy from Dr. Jiggy. Chemotherapeutic agents are cytotoxic to rapidly dividing cells by various mechanisms. Chemotherapeutic drugs eradicate the cancer cells, but remember, it can also destroy normal cells. So generally, the adverse effects are reversible but can have long-term adverse effects, as Dr. Jiggy already said about adriamycin. So almost every system is affected. And I'm showing the same chemotherapy man. You can have nephrotoxicity, hematotoxicity, neurotoxicity, as I said, a direct or peripheral neuropathy, cardiotoxicity, the patient can have stunned myocardium, pulmonary toxicity, hepatotoxicity, it even in the eye and the ear, ototoxicity also. So we heard in detail about the adriamycin-based cardiotoxicity, and cyclophosphamide is also known to cause cardiotoxicity. So this toxicity occurs within days of treatment, and many times it is reversible. Chronic toxicity can occur with a progressive decline in cardiac function and symptoms and present as congestive heart failure. Apart from this, they also can have arrhythmias. And next is anorexia and malnutrition because of chemotherapy. The cause is loss of appetite, altered smell, chemotherapy induced mucositis, nausea, vomiting, diarrhea, or constipation. So they develop malnutrition, poor weight gain, and weight loss impacts the growth development. Poor nutritional status in children can delay or decrease the cancer treatment. Next is risk of infection and immune suppression. The cytotoxic chemotherapy causes immunosuppression and are vulnerable to infection by opportunistic organisms. Again, radiotherapy. Radiation therapy uses a high energy radiation beam to destroy the cancer cells and shrink tumors. And we can have photon or proton, chemotherapy. And these are designated specific cancer area in the body, and it is a measured dose is targeted on them. It causes cell death of both cancer cells and normal tissues by causing damage to the cellular DNA. Children will need GA or sedation to tolerate the procedure, though painless, as they need to lie still. So the problem here again is radiation causes desquamation of dry and moist areas and present as mucositis, pruritus, ulcer, and pain, and trismus if it is given for a prolonged time. Xerostomia or dry mouth occurs when the salivary gland is damaged. Analgesia, dietary changes, and meticulous oral care, and in some children, TPN is the treatment. So radiotherapy has inhibitory effect on the growth of the developed bones, and many of them can develop a stunted growth. Radiotherapy can affect the thyroid, endocrine, and pituitary glands. So they can have precocious puberty and hypothyroidism. And as I said, behavioral changes, IQ decline, and cognitive decline and memory issues occur in these patients. So the cardiopulmonary effects we already heard. The child can have pericarditis, pericardial effusion, fibrosis with impaired pulmonary function. So immune therapy is this is the latest now. It is designed to use the patient's own immune system to eradicate the cancer. Use of cytokines, manipulation of T cells and vaccines, etc. are used in this. Fewer long-term toxicities than chemotherapy and radiation is seen with immune therapy. So what about anesthesia? Children with cancer undergo multiple investigations, surgical procedures, and interventions that require general anesthesia as part of their management. Especially in radiotherapy, clothing, blankets, and warming devices may not be permitted near the targeted radiotherapy site, as they may cause the radiotherapy deflections, scattering, or dampening. So raising the ambient temperature and using warming devices should be outside of the treatment field in these patients. And the problem with pediatric onco-anesthesia is anesthesia may be frequent and intermittent, and they need long-term intravenous support. So for which they are, a chemoport is placed for chemotherapy, hydration, getting blood samples for investigation, avoiding repeated injections. So when you give GA for chemotherapy, please look for, thrombocytopenia and coagulation before putting in a USG glided pace placement. A chemo port, is a blessing to the child because fewer needle sticks are needed for medication, fluids, nutrition, blood products, and blood samples. So it can stay for a very long time. So as I said, when you're giving GA or you're giving sedation, please ensure that the child does not have thrombocytopenia and coagulation issues. A mask, you can hold a mask, or you can use an LMA. Nowadays, we use LMA for ultrasound guided port placement, or the child can get a PICC line, Grochon, or a central line. So, what about anesthesia in CT MRI suits? It's again sedation and GA is given for anxiolysis and immobility. It's a NORA, mind you. So, adverse events due to unfamiliarity of the environment and equipment and drug present there can happen. Again, even if it is a lumbar puncture or bone marrow biopsy for which you are giving some sedation, look for thrombocytopenia before doing these kind of procedures. So, what are the challenges we face when we are giving anesthesia? Apart from being a remote site anesthesia, the loud ambient noise of the MRI, radiation safety problems in the RT suite, communication problems due to inaccessibility of mobile phones in case of a problem. You know, in other areas, we can easily use our mobile and call for help. And here, you know, even though not having a mobile phone helps in, you know, concentrating on the patient, again, when there is a problem, here is a place in MRI where you cannot use a mobile phone in case you have a problem. Patients often have delayed gastric emptying. Children may have infections or illnesses that carry an increased risk of complications under general anesthesia. Long-term intravenous access in radiotherapy, where when you're putting a chemo port, please pay attention to maintaining line asepsis, and the lines have to be flushed in the end. Unfortunately, even in KM hospital, we come across, you know, patients in which the lines are completely blocked, and then they send the patient for redoing a central line in these patients. Airway edema and swelling, especially head and neck tumors, can occur, and these are the patients who are at risk for laryngospasm. Be very watchful about airway edema is in these patients, especially when you have swelling in the head and neck tumors. Subglottic stenosis due to recurrent endotracheal intubation may be present, and that has to be evaluated before. And in the CT MRI or the RT suit, you have to, pressure points have to be padded, maintain normothermia, and remember, many of them, because of the cancer chemotherapy, they may already have taken antiemetics. Try to avoid double dosing on these patients and look at the laboratory values before giving anesthesia. A minimum acceptable count level and the hemoglobin level should be confirmed with the clinical oncologist. So, in the radiotherapy suit and the brachytherapy suit, you can have challenges due to face molds. They interfere with airway patency, disrupt the position of any airway device in situ, obstruct the movement of the chest with ventilation, delay immediate access to the airway in an emergency, and skin damage or pressure sores can occur. Way back in Tata, when we used to do this, we used to give IM ketamine. So the problem with this IM ketamine was every time the child came, we had to give a higher dose because we used to face a lot of tachyphylaxis in these children, you know, and you have to monitor respiration and, you know, saturation in these patients. So what are the drugs which can be given for procedural sedation? You can give propofol, 0.5 milligram per kilogram IV. Midazolam can be given IV, intranasal, or even oral midazolam. IM or intranasal ketamine can be given at 5 milligram. Intranasal will be 5 milligram. IV will be 1 milligram per kilogram. Ketofol can be given, ketamine with propofol, wherein you give 0.5 milligram per kilogram of each. Fentanyl, 1 mics per kilogram. Remifentanil, 0.05 to zero point 0.1 microgram per kilogram per minute can be given. Remimazolam can be given at the dose of 0.01 to 0.3 milligram per kilogram per minute. Injection dexmedetomidine is a very favorite drug for procedural sedation, 0.5 to 1 mics per kilogram. It can be given oral or it can be given IV also. Oral melatonin is also tried as procedural sedation, and syrup triclophos 75 milligram, our favorite drug during our age-old times. But remember, when you're giving your procedural sedation, you have to look whether the child is in minimal sedation or moderate sedation, deep sedation, and you have to look, maybe you may have to, support the airway or hemodynamics, because the even though we are talking about these various drugs and the doses, each child will react in a different way. So you have to be very, very alert and observe the airway and respiration in these children. So in small children, what we do in MRI in KEM hospital, we give an inhalational induction with sevoflurane and oxygen and using a mask, and we secure the mask with a harness and allow the patient to have spontaneous ventilation after a good ketamine pre-medication. So what are the challenges in anesthesia when you're giving for the procedure, surgical procedure? So you have to step up your monitoring. The child can need an A line, CVP line, non-invasive cardiac output or NIRS monitoring, GA, GA with RA, which could also include not just epidural, nerve blocks can be given, total intravenous anesthesia can be given, or as I said, you can even do it under sedation. A choice of endotracheal tube or LMA can be used. In our institute, most of the time we would use endotracheal intubation. Opiate-free anesthesia using combination of lignocaine 0.03 milligram per kilogram per minute, dexmedetomidine 0.5 mics per kilogram per hour, Maxulf, ketamine, paracetamol, gabapentinoids, etc. with loco-regional anesthesia is studied for avoidance of cancer recurrence and can be used in children as well. So in our hospital, we do give plenty of blocks, and if it is a laparoscopic surgery, if it is an open surgery, we prefer epidural or caudal epidural in these children. Again, presence of a mediastinal mass presents challenges in the NORA suit. So if you have a child who has a history of hoarseness or SVC syndrome, has compression of the airway, a raised ICT, inability to sleep supine, so you have to get the history properly in these patients, because these are the patients where you can have a collapse in the MRI suit. So you have to be very, very careful in these patients. And when you're giving anesthesia, you make sure that you maintain spontaneous ventilation with sevoflurane with oxygen in these patients. Have a cardiothoracic surgeon as a standby, and in case we need to take the child, you're not able to ventilate the child because of because the airway suddenly gets compressed, then you have an emergency, turn the child to the lateral position or to the prone position and get the child out. So that is the most important thing you have to remember when you're giving anesthesia for mediastinal mass in a MRI suit in these children. Again, Wilms tumor. One of the very common tumor which we find in children. You can have a large abdominal mass. You watch for chemotherapy-induced side effects in these patients. And these are the patients because nephroblastoma grows so rapidly. There is no coping mechanism in these children. And these children can present with tachypnea, dyspnea, hypertension, tachycardia, hypoproteinemia, and hypercoagulation. It may invade the vasculature. If very large, the child may have hypotension and pneumonia due to splinting of the diaphragm and raised intra-abdominal pressure. Multimodal anesthesia is the order for children with nephroblastoma. We give GA with epidural with least narcotic dosages. We don't want the child to have respiratory depression in the end. So we try to give as least as possible, manage with lots of blocks and, and general anesthesia. you're giving paracetamol and, paracetamol. So again, as I said, chemo port is very, very essential in most of the children, because taking multiple, almost all the peripheral veins are completely not available in these children. And, also these ports are, they have less irritation because these are large vessels, there's less thrombosis. So these, even when you're injecting through the port, use prilocaine when the needle is inserted into the port. Have aseptic protocols, and when the catheter is used, to minimize the risk of infection in these cases. Again, nutrition can pose a big challenge when we are giving anesthesia. So it affects the healing. If nutrition is inadequate, nutrition through the nasogastric feeding tube, especially in children who develop oral mucositis and loss of appetite following chemotherapy, should be done. Anesthesia support may be required for insertion of the nasogastric tube or a gastrostomy. For those unable to have enteral nutrition, vascular access under GA is required for parenteral nutrition also. Again, surgery can be curative or palliative in children. GA, as I said, with regional or blocks, is the most effective way of giving anesthesia. All side effects of chemo and radio is evaluated, like getting the hemoglobin, coag profile, electrolytes, hepatic, renal, cardiac, pulmonary rearrangements. All of them have to be optimized. It can cause torrential blood loss, and you may need to give massive transfusion to these children. And syndromic oral head and neck and thoracic cancers may present as anatomical or physiologically difficult airway. So you have to be ready with your difficult airway armamentarium. And if it is a physiological difficult airway, you have to treat the hypotension, hypoxia immediately. Again, critical support is very essential. Early contact with the pediatric intensive care unit is needed when there is a progressive neurological deterioration or GCS. Pain in children have to be evaluated, and it has to be treated. Around 70% of the children with cancer suffer from acute pain. A dedicated pediatric oncological pain specialist, including anesthesiologists, pediatricians, and psychologists, should care. GA for giving plexus blocks or nerve blocks has to be given, because if they will not tolerate any kind of blocks without any general anesthesia. Opiate-free treatment is preferred to avoid addiction and adverse effects, including death. So chronic pain again may be a problem in these children who have received chemotherapy or immediate surgery and things like that. And even for that, chronic pain has to be treated, and KM is one of the centers which has started treatment for even chronic pain. So you have the children can come for anesthesia for follow-up MRI scans. So the approach at this point of time will be different, because they would have completed their treatment, they would have grown up a little bit and achieved their childhood milestones. You have to still watch for long-term adverse effects of cancer therapy, which can cause permanent physiological changes. So to conclude, the perioperative care for children with cancer depends on the stage of cancer, the condition of the child with cancer at that point of time, and the type of procedure required. During the entire cancer trajectory, the patient's physiological condition may change accordingly. So the anesthetists need to be aware of the basic understanding and impact of the cancer and cancer therapy to design a safe and sensible approach without compromising the patient's safety, emotional, and the physical well-being. And whether this is conducted in or outside the operation theater, the principles of anesthesia remains the same, taking into account all the above factors. Thank you very much.
Indrani madam, I must really salute you. A very, very difficult topic, and you have covered it so nicely, so extensively, and emphasizing on all the important points. It's really, really important for all the institute as well as the private practitioners. Excellent, madam. Excellent. Not at one point also did I blink. Not at one point also we were away from the slide. We were continuously with you. Madam, we would like to know the cancer itself in pediatric patients had many side effects, as you said, increased intracranial pressure, tumor lysis syndrome. So, even for CT MRI, apart from CBC, we should be asking electrolytes, calcium, magnesium, PTINR, RFT, LFT.
If the child has received chemotherapy or radiotherapy, then yes. But generally, we do ask for electrolytes in these patients, even if they are coming for a CT MRI. And what else you said? Coagulation profile.
Yeah.
Yes,
Or
yes, we do ask for it.
so for a private practitioner, so I asked for a CBC, electrolyte, and PTINR.
PTINR, yes.
Okay.
Because cancer by itself is a procoagulant, state. So that's why.
And what about the pain relief in patch or suppositories or facial blocks? You talked about the epidurals and the nerve blocks. Do we give facial blocks or do we apply patches? I don't think patches less than nowadays fentanyl patches, they say 10 micrograms are available. I have not used it. What is your experience, madam?
Even we have not used fentanyl patches because in KM hospital, we don't have the narcotic license, and we are not using fentanyl patches. And facial blocks, you said, yes, it is going to help, definitely.
Okay. And regarding one of the pre-medication, you said oral melatonin. Even in Patna, I heard one, two papers regarding this. So, is it really helpful, and should we look at it?
Yes, oral melatonin does help. The only problem is the child will take a good 1 hour to sleep. And
Oh,
so you have to have a dark. See,
okay,
melatonin will
okay.
work
So,
only in a dark environment. So if you have light, it is not going to work no matter how much you give. So you have to have a dark environment, especially when you're giving melatonin. But melatonin is a good drug. It has been tried for, for all these Nora suits, for sedation. It has been tried.
okay. Madam, you said there could be, because of neutropenia, the triad of fever, pain, and chills. So, suppose I have to take for a procedural sedation, I have to
Hmm.
take this cancer patient, and the patient has fever. So, do I postpone it or take the patient, or do I investigate further?
The child is
For
having
example,
sepsis.
yeah, no, just fever. So, and neutropenia is there
Yeah.
for chemoport insertion, say.
No,
So,
you
what?
have to stabilize the child before taking it up.
Okay, so neutropenia, how much neutropenia should I, like I'm okay with if I'm inducing the
I
child?
have no idea. I think the
Oncologist will tell
yeah,
us.
they are the right persons to tell you. As I said, you have to, as Dr. Jigi also said, always consult an oncologist to know how
Okay.
much should be the count and how much should be the hemoglobin, whether it is safe. So always
Oh,
have a consultation before you can, take
so
the child for
even
anesthesia.
for anemia, we need to consult the oncologist.
Not anemia. Anemia, we already know that, anything less
Okay.
than 7, you have to, be watchful. Otherwise,
And platelet, you said, madam, less than 40K,
40,000.
then 40,000.
40,000.
Yeah,
Yes.
yeah, we need to transfuse. Like for the major surgery, you are saying, or for even for procedures, say biopsy or
Yes,
other,
any procedure. You
any.
cannot see many of them come for, bone marrow biopsy, or they
Yeah,
put for
yeah.
chemo port insertion. So they come for such kind of procedures. So for everything, you have to have a proper, at least, a count more than 40,000.
Okay. So in a private practice, I do my CBC, electrolytes, I do my PTINR, RFT, LFT, and I check with the oncologist about the WBC count. My platelet count should be more than 40,000. And even
Yes.
if the patient has fever or pain or neutropenia, I
I think
first stabilize.
neutropenia, yes, if anything less than 2000, I think you have to worry about.
Okay. And you said something about magnesium sulfate, madam. Is it used like as a
As a
pre-medication or
non-opiate anesthesia, it's a part of,
okay,
non-opiate anesthesia
multimodal?
combination, you know, that
Mhm.
can be used. Yes.
And one question which was there in the chat box, whether we can give anesthesia drugs through the chemo port, whether we can
Yes.
give propofol
Yes,
through the
yes,
chemo
yes.
port,
Propofol can be administered. Yes.
and then how much mLs we need to flush after giving propofol or anesthesia
Yeah,
drugs?
that's a very good question. So again, if it is a very small child, 1 year and less, be very careful about how much you're flushing. And if it is an older child, then you can flush with either, 5 ml or 10 ml, but you have to flush.
Okay. And for if it's a less than 1 year,
2 ml,
2 ml.
2 ml.
Then we see that this patient have hypoproteinemia. So do we consider their albumin count also preoperatively?
It's nice
Or
to have it, but the problem with hypoproteinemia is you have to use lesser amount of anesthetic drugs. So that is the that is more a problem than albumin. Hypoproteinemia can be seen in these children who are receiving, because they don't even eat properly. Nutrition is a big issue, and all these problems. And if it is metastasis, or if it is a liver cancer, you can have hypoproteinemia in these patients.
is albumin given to these patients preoperatively before a major
I
surgery?
suppose so. If the patient is having anasarca, if the child is having anasarca, I think you have to give albumin.
And as you rightly said, mediastinal mass is the most difficult, like for us single-handedly who are managing. So
Yes.
either for CT MRI or even for
I would
normal
suggest
induction.
don't handle single-handedly, because mediastinal mass is in a child. You know, as I said, a pre-op history to know the compressive symptoms and know at what position the child is comfortable. So try to keep the child in that comfortable position as much as possible, and don't, I mean, as far as possible, please have a help. And as I said, even if it is a huge mass, and and doing the child in a CT or an MRI, you should have you should have a surgeon standby, because in case you end up with a problem, then you need to take the child immediately, which means you need to do it only in a tertiary care hospital or cancer hospital.
Okay. And
Shilpa,
sorry.
for a
So
minute,
you want to add something? Yeah.
I was not there for the whole of Indrani's talk. Maybe she covered it. But this mediastinal mass is very interesting. And, many children may come for a simple, lymph node biopsy, a
Yes.
cervical biopsy or a axillary lymph node biopsy, which is actually, we all most of the time think it's tuberculosis or something like that, but sometimes it's a lymphoma. Or and that child may also have a mediastinal mass, and unless you've taken an x-ray, you may not know that there's a mediastinal mass. So always be very careful when you're doing a cervical node biopsy in some of these children. So sometimes you're taken unawares by the fact that it's a simple cervical node biopsy, chal kar le chota idhar udhar, and then suddenly you find that there's airway obstruction and
Yeah, suddenly you
very
have,
exposed.
the
Be a little.
patient collapsing in front of you. Yeah.
So we should always intubate these children even for biopsies.
No, no, no.
No,
I
no, you
wouldn't
need.
keep the
On
patient
LMA is
on
okay.
spontaneous. That's what I said.
Spontaneous,
If the
yeah.
child is coming for a CT MRI, I will hold a sevoflurane, and I will, or I can put an LMA, but I will
LMA.
try to keep as spontaneous as possible. The minute you try to intubate and, give a muscle
Yes.
relaxant, you're
Yes.
done. So
Yes.
be careful about that, especially
Nowadays,
in a NORA suit.
Nowadays, the incidence is less because almost everyone gets a X-ray or a CT or something, the way
That's right.
people. So but in
So
some years, when people are very conservative about X-rays and this and that, so the occasional problem used to come up.
yeah, Jiggy, the only thing we have before we take up this child in a CT or an MRI suit is only an X-ray, So that's the only thing which is in front of us. So if, God forbid, if it is compressing on completely on the trachea or one of the, on the heart or something, then we had it. So as Dr. Jiggy said, don't take even a small lymph node lightly.
Yeah. Yes. Rao sir, you want to say something? Probably we have time constraint.
Yeah. One last question. There is a question in the chat box. Like Vijay sir has already talked about chemotherapy and management. There is one question about the alternative therapies most of these people take and come. Powders and churners and all those things.
Yeah.
Any word of caution regarding such patients who are already on these so-called alternative methods?
Yeah, I wish you had listened to Dr. Jiggy in Isocon. He said that, it is very easy for us to fall prey to these herbals. But remember, time is ticking for you, for this child, So if you lose time by trying all these alternative therapies, then probably you are doomed, You have to be very careful. So I agree. Chemotherapy, radiotherapy, all of them are very, they are toxic. But then it all boils down to the need for survival with the quality of life, isn't it? So remember, today we have effective targeted therapy, so it can spare normal tissues, and we have neuroprotective therapies, and you have, even radiation therapy can be, targeted. So since, cancer treatment has improved so well, I think we should not waste time in all these herbals and concoctions and,
This is a
all
more
these things. And
important.
I think this message has to go across, because remember, pediatric cancers, most of them are treatable. 85 to 90% of them live a normal life after treatment. Nothing to worry. Unlike an adult, I would not, the percentages are much, much lower. So please remember, pediatric cancers, you should go for a regular treatment, a combination of treatment of, radio, chemo, and surgery, whenever, as has been, targeted to the child.
Just to add to that,
More relevant and because of the recent celebrities Neem and Haldi in breast cancer.
but Dr. Rao, you raised an important point. Many patients do take
Yeah.
alternative treatments. They may
Yes.
not even tell you they've taken that. Right. So if you come across something very unusual, someone not responding, think about it. If they've taken herbal treatment and you don't know what that pudi contains, if you're really worried, you can get a heavy metal sort of tox screen done if you want.
Yeah.
But anything funny happening, think about this sort of thing and ask the question. Some have taken steroids in that pudi, and they may have some. And if you don't cover with the steroid, they'll get sudden hypotension, shock, and all after a major stress operation. That sort of thing. So all these funny things can happen. So if you find something going on, always ask for that history.
And coagulopathy too.
Yeah.
Yes.
Anything.
Because all those ginkgo and, garlic, whatever they give, they, all that powder they have, saying that, it has got anti-cancer properties, they also work on coagulation. So remember that also.
Yes, madam, my own nephew took, I mean, of course, he was in the last stage of cancer, and they went as a last resort to Dehradun, where they took some Ayurvedic medicine, and he just bled from everywhere.
That's all.
He just bled from everywhere, and he just, it just ended badly. So I think this is a very gross point where people really give up and they just go to Ayurvedic, and it has more side effects than any advantages. So,
Especially with people like Navjot Singh Sidhu
oh yeah, he's
coming
made
out with such videos.
like diet can help eradicate or treat breast cancer, which is ridiculous. Already, Tata Memorial has issued a letter
Yes,
saying this
Yes,
is a
yes.
fake statement.
that's right.
Yeah.
Neelam,
Thank you
can we
so
move
much,
on?
madam. Yeah, over to Neelam, madam. Thank you so much, Indrani, madam. Yeah.
Thank you so much, madam. So now we move on to our last session, which is very interesting and much needed. We all need the surgeon's perspective in everything, but today's topic is reconstructive surgery, a surgeon's perspective. Speaker for this topic is Dr. Ritesh Gupta, sir. I'll share his slide. So Dr. Ritesh Gupta, he is a renowned board certified plastic surgeon with more than 10 years of experience in this field. Currently, he is practicing in Mumbai with special expertise in breast cancer reconstruction. He is attached to Dr. LH Hiranandani Hospital, Holy Spirit Hospital, Holy Family Hospital, BSCS MG Hospital, HCG Apex Hospital, Godrej, Sushrut, Masina, and Bhakti Vedanta Hospital. He is honorary member of many associations such as Plastic Surgeons of India, Aesthetic Plastic Surgery, Breast Surgeons of India, Indian Medical Association, AMC, and many other regional associations. His topic is reconstructive surgeries, a surgeon's perspective. And the moderator for this session is Dr. Rajesh Rao. Dr. Rajesh Rao is Secretary, ISA Borivali branch. He is anesthesia practitioner in private setup for more than 30 years. He's director at Galaxy Healthcare Hospital, Borivali East. His special expertise is in segmental spinal
Pure.
and no, I would like to add one more. Dr. Rao is pioneer in our area who started doing lot of cases in segmental spinal anesthesia during COVID times, and now he is invited as faculty for workshops in various conferences all over India to conduct segmental spinal anesthesia workshops. Over to Dr. Dr. Rao, over to you.
Thank you, Dr. Neelam. It's my pleasure to introduce Dr. Ritesh Gupta, good friend. I've been associated with him for few years now. We do a lot of pre-flaps. We started doing it maybe 5-6 years back, where the time was a little more, but now Ritesh has created a good team. So he does the pre-flaps within 4-5 hours. And in continuation with our ISA Borivali of inviting our associate colleagues in our discussions, I would like Dr. Ritesh Gupta to share his perspective in the oncosurgery department.
Rao sir, I would like to add one sentence. Dr. Ritesh Gupta sir also comes at Bhakti Vedanta, and personally, even I am very impressed with his work. He really does a very clean, neat work.
Yes.
Is my screen visible, and is my voice audible to you all?
Yes, sir, very much.
Yes.
Okay. First of all, to begin with, I would like to thank ISA, Dr. Rao sir, and Dr. Shilpa madam to give me this opportunity to speak about a plastic surgeon's perspective in terms of onco reconstruction. And in this presentation, I'm not going to discuss a lot of theory because I believe more of in surgery. I'm going to walk you through a plastic surgeon's role in cancer care. What are our viewpoints? So the basic question that any right from the patient to other people they ask is, why is a plastic surgeon involved in onco cases? In fact, plastic surgery does not actually specify which particular organ or which particular system we are involved into. So plastic surgery For me, it is very simple. We are the surgeons who treat function of a patient, be it the function of eating, speaking, or drinking water, even facial contour in head and neck reconstruction, be it the function of regaining lost body image, gaining back the identity in cases of breast cancer with breast reconstruction, or be it gaining back mobility in limb reconstruction. And particularly for reconstructive surgeon, everything revolves around one particular word, that is flap. In simple words, flap is nothing but a tissue of skin with fat, sometimes muscle, which is taken along with a blood supply and shifted from one location of the body to the area where it is needed. But flap surgery in itself has many challenges. It has a very steep learning curve. I remember when I started my residency, I would be told by my seniors, एक हफ्ते बाद free flap surgery है. That means it had that kind of terror during our residency, as if it is something which is very rare and we have to be very well prepared on our toes for that particular. But it has improved with time. It requires a lot of patience. On an average, every flap surgery has an average 6 to 8 hours surgery required from the plastic surgeon himself. The climax part of this microvascular reconstruction is that the microsurgery part of it, the anastomosis part of it, comes at the very end of the surgery. And usually we try to finish it by 5, but sometimes if we have an unlucky day, it comes to around 8 to 9 p.m. Just try to imagine that time where mostly the staffs have finished their duty. They are going, they are planning a shift. They don't have any food or anything for their dinner. They just have bought only a tiffin for the afternoon. At that time, everybody is exhausted. So patience is something which is very much needed at that point of time. And the greatest challenge in a free flap surgery is a failed result. The point is, a failed result is like a spot diagnosis. Before we try to close that area, we go and check the flap by scratch test. Luckily, if we find everything okay, we close it. But unfortunately, one bad day, if we find a scratch test showing some kind of congestion or no bleed, we don't know whether things are going to stop. And we can't just leave the theater. We need immediate action. So the question is, if flap surgery is so complex, why should we go ahead with such kind of complex surgery? The point is, nowadays, cancer treatment has shifted its focus from only survival to improving quality of life. We have seen great improvement in patients' overall quality of life, getting back to completely a normal human being. People can't recognize whether they were a cancer patient or not because of plastic surgery, because of flap reconstruction. Our basic aim is to give a good long-term benefit to the patient compared to the short-term risk that the patient is undergoing because of flap surgery. Our basic aim is that cancer should be just a chapter and not the entire book in the patient's life. Usually our anesthesia colleagues, they don't get the chance to see any particular patient after flap surgery, the long-term benefit that the patient is given. So I being a only plastic surgeon in this group, I have this opportunity to show this particular video where this is a 71-year-old lady who has a recurrent CA tongue. She came with us, we tried to record her voice and we wanted to see whether we can give her a good voice quality after surgery. We did a free radial artery forearm flap, that is a flap from the forearm harvested along with the radial artery and the cephalic vein, and we used it for reconstruction of the CA tongue. This is the video of the patient before surgery. Sorry.
Hare Krishna Govinda Mohanam Murare He Nath Nara He Vasudevam. Hare Krishna Govinda Mohana Murare He Nath Nara.
Now, what I am going to show is the 1-year result of the patient. you could appreciate the voice quality that the patient has got, and you can see the movement of the flap, which is supporting the movement of the tongue after 1 year.
Hare Krishna Govinda Mohan Murare Nath Narayana Vasudevam.
मुंह खोलो, जीभ बाहर निकालो, अंदर करो, इस तरफ करो, बाहर निकाल के, अभी इस तरफ करो, जीभ दोनों तरफ हिलाओ अच्छे से. So what you could see is, बहुत अच्छा. As a surgeon, as a reconstructive surgeon, our basic aim is, irrespective of whether the patient has any medical comorbidities, whether the patient is an elderly patient, our first responsibility is to give the best possible quality of life to the patient. And in this, the best weapon that we have is a free flap. In case that best does not work, we try the safest possible option. But our first thinking is always let's give it a try. Now coming to some theoretical discussion, this Poiseuille's equation forms the basis of anything and everything related to fluid therapy and vasoactive drug treatment in free flap cases, where we can see that the flow of for vessel for the flap is directly proportional to the pressure gradient and the radius, and inversely related to the viscosity and the length of the vessel. What important factor we take from this is that the effect of drugs, especially vasoactive drugs and vasoconstrictor vasodilator, even a single 1 mm change in the radius of the vessel will increase the flow to by 16 times. This is very important factor, especially with the medicines that we use. That is why most of the times after we finish off the flap surgery, we irrigate that area with almost hot saline. That is why at the end of the surgery, we ask for papaverine. And other important factor is maintaining a proper pressure gradient. Most of the times I ask my anesthesia colleagues to increase the blood pressure by the mean to around 80 to 90 millimeter of Hg. Third, equally important is reducing the viscosity of the fluid that is going through the flap. How different is flap hemodynamics from the other tissues that are there in the body? Every tissue is receiving, especially the skin is receiving its blood supply from the subdermal plexus. But compared to all other tissues, flap are denervated. We only take the blood vessels, we only take the artery and the vein. So they lack intrinsic sympathetic tone. Beyond this, arteries and vein, I don't know, they become super sensitive to external stimuli like temperature and medications. And third important factor is that they lack lymphatics. So there is a very high chance of interstitial edema. So this is an image of two flap, which I am trying to explain the physiological importance in terms of fluid therapy and other vasoactive drugs. On one side, we can see a major radial artery and cephalic vein taken along with a smaller chunk of tissue, 9 by 6 centimeter radial artery forearm flap, may be used for malignancy of the tongue or lip. Here, in case the pressure changes are fluctuating too much, since the supply is too much compared to the demand, the flap may survive any physiological changes. Now, compared to this, on the other side is a whole tummy skin, which is a 30 by 15 centimeter flap, and the supply is only a small 1.5 to 2 mm perforator of the deep inferior epigastric artery. That big, almost 600 to 800 grams of tissue. Here, the function is, for me, it is same, joining the artery and the vein under microscope. But here, physiology plays a very major role. So, fluid therapy is important for some cases of flaps and may not be a major role for some cases. Now, coming to fluid therapy, I had gone through many articles understanding what is an ideal fluid therapy for every flea flap. I found articles mentioning goal-directed fluid therapy for microvascular flea flap. There were certain articles which mentioned fluid-restricted therapy for flea flap. And as a surgeon, I could not be a very good in calculation of the amount of fluid that the patient should be given. and all these articles were from medicine or anesthesia. So I thought of looking into any article which is from the plastic surgery side, and I found when is enough. So basically, what I plan, I went through this article which the Canadians had done. They had a comparative study between they themselves restricted their fluid from 2011 to 2014. They had fluid overload, and then from 2015 to 2020 they started restricting the fluid and started increasing more of vasopressor drugs to improve the perfusion. And what they found was the success rate of flap was better in the later part after 2015, and even flap necrosis, partial necrosis, total necrosis numbers reduced. One major important factor along with this is the duration of anesthesia, which actually is the surgeon's responsibility. We can see that the blue graph, if the duration of anesthesia is less than 12 hours, the flap compromise and major complications were very less compared to the green one, which is 14 hours. I read in one of the article that 1 hour increase in the anesthesia duration leads to increase in the surgical complications by around 19%. What I routinely follow is normovolumic pressure. There should be for the whole duration of surgery or for the 24-hour period, the fluid therapy, total fluid should not go beyond 3.5 to 4 liters. I try to maintain normotensive. I ask my anesthesia colleague to maintain a pressure of around 80, sometimes 90 mean, and I ask them to maintain a urine output of around 80 to 100 ml per hour. This is what I expect from my colleagues during the surgery. What about patients who are having hypotension? Sometimes, like the article that I had discussed, fluid therapy is not the answer, especially in microvascular free flap. So we have vasoactive drugs, but which of the drug is the drug of choice during these cases? So here we have an article where they judged the drug with parameters like whether it increases the mean arterial pressure, and in case of distribution of blood, how much is the comparison increase in the blood supply to the flap compared to other body tissues. And they found that noradrenaline is a better drug of choice in such cases. You can see that the red line, which is the perfusion of the flap, is better with noradrenaline, even though it is a vasoconstrictor, compared to other control, that is normal tissue. Because here the mean pressure is more active, and it shows that at better concentration of noradrenaline, it gives better perfusion to the flap. Other important factor in free flap microvascular surgery is temperature regulation. And at any cost, we must avoid hypothermia and use these modalities like fluid warmer and body warmer whenever possible. Now, when Dr. Rao told me to make a presentation on free flap, reconstructive surgery and anesthesia, I was a bit worried what I'm going to talk about this. But I had a lot of experience, and I wanted to share in terms of what I expect from my anesthesia colleagues during my free flap surgeries. To begin with, let me share my experience. Because everything, the expectation is same from a plastic surgeon and an anesthetist during a free flap surgery. I am a solo practitioner. I'm working in many hospitals and many types of hospitals. And with time and experience, I felt that free flap surgeries demand a lot beyond just surgical skill and knowledge. It demands some kind of soft skill also, and that are important for the success of both the flap and the surgeon and the anesthetist. And some points were relevant to not just the surgeon, but my anesthesia colleagues also. And I could see that most of the anesthetists were following this very nicely. But usually by this PowerPoint presentation, I felt that I would share this recommendation for people who are new into practice or someone who is facing an occasional onco reconstruction case. Usually for a microvascular surgeon, the success rate is 95 to 98%. Now, if we look into it from the other side, it is 5 failed flap per 100 cases. That means if I'm doing 20 cases a month, I know that one case will fail. And that one case is enough for me to forget all my other 19 cases. For that particular patient, it is 100% failure. And no one, the plastic surgeon, the oncosurgeon, the hospital, the patients, and the relatives, no one is prepared for a failure. By my personal experience, I can say that if in one particular hospital I have a flap failure, the hospital won't call me for another 2 years. So these recommendations, I have some 4-5 points which can be benefited to you all. You must know your flap. Many hospitals that I go, the basic thing that I see in the list of the surgical list is that it's a commando surgery. Commando surgery is one type of surgery. It does not describe what type of resection is happening and what type of reconstruction is happening. So understanding about in detail, not necessary, but understanding of what exactly the reconstruction and what exactly the resection is going to happen is very important, basically for managing things very well. In simple terms, these 3 are the workhorse flap that we are based upon. A bone flap called free fibula flap, and then soft tissue flap like free radial artery forearm flap and free anterolateral fly flap. One important point is, in case we are planning a free radial artery forearm flap, the non-dominant hand, we don't allow to prick the cephalic vein. It is very important to have a communication with the plastic surgeon beforehand. I still remember every case when I worked with Dr. Rao sir. 2 or 3 days pehle, he would call me up, Ritesh, what is the case? What is going to be the reconstruction? And kab tak hoga? Kitna time lagega? All that was the question. That means he was prepared enough to understand what is going to happen during the surgery, when the surgery is going to get over, and how he may plan his day according to that. A lot you can understand based on the documents that you see from the oncosurgeon, like marginal mandibulectomy, mostly a soft tissue flap. Sometimes a segmental mandibulectomy, that means fibula flap, 2 hours extra. You can also judge a lot based on the clinical picture when you are trying to examine the patient during the preoperative anesthesia checkup. Like the upper picture, there is a lesion in the retromolar trigon. That means the posterior part, the vertical part of the bone is going to go in such case, and in most cases, it is going to be a soft tissue flap. But in the lower picture, the lesion, although looks similar, but it is a bit anterior. So maybe the cancer surgeon might do a segmental, and we may reconstruct it with a free fibula flap. So all this idea can give you a better judgment of how much time, how much duration of surgery we expect during the main day. Sometimes looking at tongue cancer also, you can judge. Like the picture on one side shows a smaller lesion, maybe primary closure, maybe hemiglossectomy, but other factors, duration of surgery is less. Patient may not require a tracheostomy, early healing, and early back to work. But on the picture on the other side, the tongue is completely involved. Total glossectomy may need a larger flap. Patient may require a tracheostomy, and length of stay in the hospital, post-operative care, ICU requirement will be extended. So all this judgment can be given just looking at the lesion. Tip number 2, I'm sorry, telling tip, collaboration is very important among the whole team. It's actually a 4-player game. Oncosurgeon, plastic surgeon, anesthetist, and the 4th player is the patient who is just lying down over there. And at the end, the 3 players should benefit the 4th one. Some of my experiences which I have seen is that sometimes we have come to a scenario where the oncosurgeon is resecting the primary, where bleeding might occur. He tells to reduce the blood pressure. At the same time, we have finished our flap harvest, the tourniquet is deflated, and we want the pressure to be increased. So At the end, you all are the team leaders who try to mitigate all these things and try to give a pressure which is beneficial to both the oncosurgeon and the plastic surgeons. Throat pack, a big problem. We have faced large numbers of problems because of this, especially in Bhaktivedanta Hospital. Nowadays, what we have done is we have started writing throat pack in time, who has inserted the throat pack out time, who has removed the throat pack, because this is very important. We are actually a two-team approach. The surgeon, along with his staff and the whole trolley, moves away after they are done. If we don't keep a track of it, we have faced problems in the past. Even gauze count is very important, because it has been noted that two-team approach is usually very beneficial to the patient, and I follow two-team approach. Immediately after the surgeon is out, I go and start my reconstruction over there, so that the duration of surgery is very low. At that point of time, I feel that a gauze count has to be checked, and at the end, we don't waste much of time thinking where exactly are we missing one gauze. One important factor which I follow is I ask my anesthesia colleague to raise the blood pressure before closure. The reason is there is a raw area of resection. There is a raw area of the flap. I have done 2 fresh anastomosis, and the veins cannot bear any pressure of the blood. So what I do is 20 to 30 minutes before I close, I ask my anesthesia colleague to raise the blood pressure by around 20 to 30 millimeter of Hg, and see to it every minor bleeder is corrected at that point of time. So I am very happy that after the surgery, even if the patient has gone back in the ICU, bleeding might not be a problem, because we have seen cases where the blood pressure was going haywire in the ICU, and we could see all the neck and the face has bleeding coming from everywhere. We had to take the patient back inside the theater also in such cases. Surgery does not stop in the OT. Surgery gets over in the ICU. Remember, in free flap surgeries, most of the patients are shifted from the OT to the ICU in an intubated state. Whether we use a ventilator or we use an AMBU machine, this patients, the shifting has to be very smooth. And you need to collaborate with the ICU intensivist in terms of whatever medication has been given, how much fluid has been given, and you need to guide them whether the patient requires any further medications or fluid therapy. Even we are there, we check the flap, and sometimes if we have an unlucky day, we have to take the patient back inside the theater. In such cases, we see to it that the position of the patient and the neck is kept in a restricted way. In terms of drug therapy, we tell our ICU intensivists to see that the patient is not moving too much. In case such things happen, we tell them to either sedate the patient first. If the patient is still not tolerating, we ask the intensivist to put the patient on ventilator back. And then we want the patient to come out smoothly. This slide is for my colleagues who are solo practitioners and who have booked 2 or 3 cases in that particular day. Believe me, you will thank me for this slide later on. Keep buffer time available and keep backup. I've learned this from my science residency days, because our surgeries during those periods used to go for 16-18 hours. And anesthesia team, they would divide their work. They would have some people from the morning to the evening time. There would be one anesthesia consultant coming in the evening, waiting during that period. Now, once I come into private practice and I see anesthesia colleague who has taken up a case, and he asked me, sir, mera 5-6 baje bhi ek case hai, whether it will be over or not. Sometimes we had bad days. We told him, yes, fine. But at the end, there were some problems in the flap. So keep 1 or 2 hours extra, irrespective of the flap. Why? Other reasons for keeping this buffer time extra is sometimes the restriction plan changes. You might get a frozen section which has turned positive. So sometimes skin excision is there. Sometimes the bone resection plan changes, and we might think of free fovula flap instead of an anterolateral thigh flap. Even shifting the patient in the ICU, we have seen that there is a congestion. We had to take the patient back inside the theater. So that particular day, you are never sure of any tough time. Next day is also a surprise. What I routinely practice is, suppose I have operated one patient in Daisar and my other patient for the next day is in Andheri. For me, it is very important to see my previous patient and assure that my flap is working before I ask this patient to get induced, whether it is at 7 o'clock in the morning or it is at 8 o'clock in the morning. The point why I'm trying to emphasize this is that in case of surprise, I will need an anesthetist. And if he has already packed his work, it becomes very difficult to take that patient at that point of time. Post-operative care is equally vital. Dr. Rajesh Rao, sir, you were talking about the recent social media article. This is one of the patients that we recently operated. He was seen by the oncosurgeon 3 months back. He took all kinds of alternative treatment. The tumor started fungating. All the food that he was trying to eat were coming out of his skin through the submental region and were trickling outside. So the earlier the treatment, the lesser the reconstruction, the faster the rehabilitation. But in his case, we had to use two flaps. One, a big 15 by 20 centimeter anterolateral thigh flap from the thigh and one chest flap for inner side. But what I want to tell is this is post-operative day 3. Here, almost I am safe that my flap is not going to be showing any necrosis. But this is the time when systemic problems begin, especially lung infection, especially pulmonary edema. You can see the tracheostomy tube. So equally important is managing the tracheostomy also. What my protocol is, I see to it that the input is urine output plus 500 cc only. Most of my patients will have an inner cannula. In case it gets blocked, it is very easy to remove it, clean it and reinsert it. I want humidified oxygen because we are bypassing the humidification part of the nasal cavity. I ask nebulization. It is 3-hourly nebulization. Every 6 hours live with dual Budecort and every 6 hours live with normal saline. And I advise early physiotherapy and ambulation of the patient. So this is from my side. At the end, I would say this is the most important slide in my presentation. Because sometimes in cases when the cases is about to get over at 3, we are very happy. We find some changes, some problem in the flap. 3 turns to 5, 5 turns to 7, 7 turns to 11. We had recent experience in this. We are looking only into the flap. We are not seeing what is happening in the surrounding. Everybody is calm. At the end, if we are happy, we don't get time to say thank you. So with this slide and with this webinar, I would like to say thank you to all my anesthesia colleagues, because I don't think we can be a good surgeon without you all. Thanks a lot.
Thank you, Dr. Ritesh. I'm happy that I've chosen the right person, and the very idea of involving our surgeon colleagues and get their perspective. You have justified it. Excellent talk. Take home messages, I would say, as you said, always talk to your surgeon before the surgery, what he's going to do and what is his expectation, and also be involved post-operatively. Post-operative care is also, see, we are there for whatever 5, 10, 12, 15 hours intraoperative, but it doesn't end there. As you said, the surgery ends in the ICU. So post-operatively, always maybe for a couple of days, keep in touch with the intensivist regarding the IV, BP, especially patients I've seen hypertensives. We manage them intraop. Onco surgeons require hypotension, you require normotensive. But then once the patient goes to ICU, all his antihypertensives are forgotten. He's on a rise tube. So, and plus whatever pain he's having, that can cause sudden rise in the hypertension, bleeding, hematoma. So I think we should take care of the patient, right? Pre-op assessment, intraoperative, and maybe a couple of days, 2 days, 3 days post-operatively. And then
Yes.
we can come out with better results. Thank you.
Because
That was an
90%,
excellent presentation. Yeah.
90% of the flap problems happen in the first 24 hours to 48 hours. And
Yes.
if we go through those 48 hours, I think we can take easy breath.
Yes. Thank you, Ritesh. Thanks a lot. It was an excellent presentation.
Thank you, sir.
Now I hand over back to Neelam.
I think Yogendra. Yogendra is
Yes,
there?
Dr.
ma'am.
Yogendra, I think
Yes,
it is
sir.
time for you.
Yeah.
Let me first thank Dr. Jiggy, Dr. Bala, Indrani to be with us for today's webinar. It was an excellent. We have overshot the time it was supposed to get over, but we enjoyed it. We enjoyed everything.
Yes, sir. Good evening, and it was indeed a star-studded evening. It was all the stars which we saw today. And on behalf of the organizing team, it is my privilege to propose the vote of thanks. On this occasion, my heart fills with lots of gratitude and respect for our distinguished guest speakers for not only sparing their invaluable time for us to grace this occasion, but also for enlightening us with their commendable talks. BSA is indebted for your support. I would like to thank and congratulate President ISA National, Bala Venkat sir, who is a great visionary, who is a true leader, and it is a dream of all the anesthesiologists to learn regional anesthesia from Sir, and Sir has taken ISA to an international platform. I would like to thank Jiggy Diwatiya Sir. Sir is a pioneer in anesthesia, and it is a privilege to hear and learn from Diwatiya Sir. Thank you, Indrani ma'am, GC in ISA National. It was a pleasure to have ma'am who has always been encouraging and supportive for BSA in all our CMEs. Thank you, Ritesh Gupta, sir. Thank you for your insight on the surgical perspective of reconstructive surgeries. And thanks for giving us those small tips, which is a take-home message for us in pre-flap surgeries. I would like to thank all the moderators, Amula ma'am, President BSA, Rajiv Garud sir, Vice President BSA, Rajesh Rao sir, Honorable Secretary BSA, Shilpa Tivaskar ma'am, GC ISA Borivali, and I would like to take this opportunity to congratulate Shilpa ma'am for receiving the Proficiency Award at the National Conference held in Patna a few days back. Thanks to all the office bearers for giving their online platform and support. Thanks to Anita Nete ma'am, Saurabh Berde sir, Rajesh sir, Avinash sir, Vikas sir, and Parna ma'am. Finally, thanks to all the BSc office bearers, Amula Parekh ma'am, Raju Garur sir, Rajesh Rao sir, Honorable Secretary, and hardworking Tejveer Singh Chavan sir, who's the scientific secretary and who has wonderfully coordinated the CME. Thanks to Kalpesh Gaitonde, Shilpa Tivaskar ma'am, Ganesh Tendulkar sir, and Neeraj Jindal sir. Thanks to Ganeka for their web platform, and thanks to all the delegates for joining this star-studded webinar,
Sorry, did
which
you
was
forget
an
someone?
and delight.
Did you
And
forget
Most
someone?
important, Neelam Nalge, madam.
thanks to the MOC Neelam Nalge ma'am for coordinating the CME in a wonderful
This
manner. And
ended
it was
without
a
thanking.
housefull webinar, and I hope many people see this video and they'll appreciate this CME. Thank you, ma'am.
Neelam madam, you did it very seamlessly,
I
very seamlessly, very nicely.
would have ended if he wouldn't have thanked me.
Ma'am, you are the
No,
star.
no.
You are the star.
Okay, thank you.
Thank you. Thank you, ma'am. Thank you all.
Thank you, Dr. Yogendra.
Good night. Good night.
Yeah.
Good
Thank
night
you.
to all. Thank you.
Thank you,
Thank you.
Diwatiya sir. Thank you, Ritesh Gupta sir. Thank you, Indrani madam.
Good night, all.